Good afternoon, everybody, and welcome to the annual general meeting of NHS West Yorkshire Integrated Care Board, the ICB. My name is Cathy Elliott. I am Chair of the Integrated Care Board and Deputy Chair of our Health and Care Partnership here in West Yorkshire. Welcome to Bradford. We have board colleagues around the table here today for our first annual general meeting, and welcome to our visitors as well who have come to join us today to hear about our work. We're grateful to you for your interest and your time today. So we have a standard annual general meeting in some ways, but I'm going to invite senior colleagues to come and share their thoughts and some points of review for us over the last 12 months and looking ahead. What you'll see behind you, if you're in the room here in Bradford, is a slide deck. What you'll see online is that slide deck for your information, and a variety of information, including our annual report, is available online for you. So, for people watching online and people in the room, there are name plates in front, and any colleague that is speaking, please would you introduce yourself at that moment? That'd be really helpful. Can I just ask, as a matter of good practice, are there any declarations of interest in relation to today's agenda for the annual general meeting? No. Thank you. Thank you. Shelley, thank you. Thank you very much, Shelley. Thank you very much. Shelley came to join us today, and she has shared her experience, particularly around maternity services and mental health services in Leeds, and our colleagues are supporting her to put that on record, and we will be responding in writing and putting that on our website. So thank you, Shelley, for sharing that with us. So I'm now going to pass on to our business that we have on our agenda today. I'm just going to ask again any declarations of interest as a matter of business. No? Okay. We are now going to hear from Rob, our Chief Exec, on reflections of our first year as a statutory organisation under the Health and Care Act. We became an integrated care board on the 1st of July last year, but very much for us as a well-established healthcare system, working together in partnership for integrated care, we were building on 5-6 years or so of partnership working and very much being a true partnership. So Rob, I'm going to hand over to you, reflections on the last 12 months.
Thanks, Cathy. Just check everyone can hear okay. Thank you very much. Hello, my name's Rob. I'm the Chief Executive. I'm going to speak for a little bit, not cover too much, and then I've got some colleagues who will also provide some reflections on quality and money and some of those issues. We are an integrated care board, which is an organisation which sits within a system. As Cathy says, that system began to work in this way in 2016. So some of the partners around the table from local government, the NHS, the third sector and our communities play a vital role in the governance of this organisation because we recognise that we sit at the heart of a system. You can look at our annual report and annual accounts, and it's full of a significant amount of positive work, and it also reflects some of the challenges that we've faced over the last year. I just wanted to pull out a few things which is important for us to clock, I think, in our first year. We have set up as a statutory body, and I don't normally start with structure, but let's do a bit of structure because it's important to recognise that this organisation was created on the 1st of July. It was previously intended to be created on the 1st of April. So I just wanted to start by thanking all of our clinical commissioning group colleagues for continuing to deliver their services and oversight through CCGs until the 1st of July, and for creating the accounts that they had to for the first quarter to meet the statutory duties that they had until the 1st of July. So when we became a statutory body on the 1st of July, we did so with following a substantial amount of work to ensure that all of the functions of clinical commissioning groups and all of the things that we want to do as a partnership were embedded in the Constitution, were embedded in our values and behaviours, and were embedded in our priorities for this year. And it's important to recognise that. And in doing so, to recognise that the Integrated Care Board is not a big CCG. I know that there are some people around who automatically think because we've picked up the functions of CCGs, that the Integrated Care Board is like a big CCG. It is not a big CCG. The Integrated Care Board sits in the heart of a partnership and is a novel organisation which brings together the third sector, communities, the NHS and local government in pursuit of improving outcomes for local people. So I'm really pleased that we were able to create an organisation that held on to the values and principles that we have as a system and sits at the heart of a system which has an integrated care partnership overseeing it, and it delivers services through places in partnership with providers. That's why we have the board that we do, which also has voices from the third sector and communities around the table. And I just pay tribute to Cathy and her leadership as the chair in making sure that that was the case and in helping to co-produce the governance that we have. So given that we set this organisation up, it's got 4 statutory responsibilities. You know, making sure that we reduce health inequalities, managing unwarranted variations in care, making sure that we use our resources wisely, and delivering the biggest possible return that we can on the investments that we receive, or the investment that we make, the £5 billion a year that we spend. And the annual report draws out some of the substantial work that we've done in each of those places. You could be drawn, for example, to the work that we've done with our Health Inequalities Academy, which recognises that we know that people with learning disability, people with mental illness, people who live in deprived populations, and people from the global majority have poorer outcomes and poorer experiences of healthcare. What we need to do is to make sure we're doing something about it. So a Health Inequalities Academy that draws on the best evidence and insight, that then looks at what capacity is required to make the change from where we want to be to where we want to go, and then make sure that we have the capability to deliver that through our public health colleagues, through professionals, through the development of a range of health inequalities fellows, is part of the answer to how we address health inequalities. You could be drawn to that or any number of bits of work. On tackling unwarranted variations in care, it's really brilliant to see the continued work that we've done as an anti-racist system and an anti-racist organisation to address systemic racism in communities and within the health and care system, so that we ensure that people from black origins, for example, are not sectioned disproportionately, to make sure that people from different backgrounds have good access to healthcare, to vaccinations, to clinically competent staff. On making sure that we use our resources wisely, there's a huge amount in there around our accounts. I'll leave Jonathan, the Director of Finance, to give you an update on that. But you'll notice that we met our statutory responsibilities on the money. And we also continued to allocate the money to places to be spent by the places with their partners, because they've got the greatest degree of insight around where the money should be invested to make the biggest difference possible. And on the biggest impact on the investments that we'd make, you know, I would ask anybody to go and visit Red Kite View to see the excellent standard of care that's delivered for children who require a hospital inpatient stay because they're mentally unwell. But the staff there, you may not realise, are being drawn from the local streets because we recruited from local communities who face significant inequity because of deprivation. because that's one of the ways that we make the biggest difference that we can. And those sorts of initiatives are littered throughout our people plan, which Kate Sims has helped helm and implement throughout this year. So those 4 statutory responsibilities, we've continued to see at the heart of what we do. They're reflected in our 10 big ambitions and in all of the work, and you can see them shot throughout the annual report. If we reflect on the last year, I think we would all recognise that it's been really tough. So between July and March 2023, I think we'd all recognise we faced professionally the toughest winter that any of us have faced before in our careers. We had significant and substantial delays in delivering care. We had significant and substantial disruptions to care, driven by a confluence of diseases which came at the same time. So we had COVID-19, flu, strep A, and various other respiratory illnesses all apparent at the same time, which had a devastating effect on our ability to deliver care. The good thing is that because we have a strong system built on places with providers in collaboration, the response to that, which is reflected in the annual report, was to work together to mitigate the risks and ensure that safe services could be delivered wherever possible. And it's testimony, I think, to the strength of the partnership that that's what we did. And in March, we came together to review the winter and see how that had felt for everybody. And when we talk about winter planning in the board meeting later today, the planning for this winter started in March this year, because that's the kind of partnership that we are. So I think it's worth reflecting that it's been an incredibly difficult year because of a range of factors and because of industrial action. We now find ourselves in a situation where a significant part of our workforce has been in dispute with the government for a significant part of the period in question. We're currently facing industrial action this week, which continues with the doctors, and our medical director, Dr. James Thomas, is the director dealing with that today, which is why he isn't in the annual general meeting. That industrial action and that fracture of the relationship between our staff and the government needs to be sorted, because we can't deliver recovery, we can't deliver productivity, we can't deliver safe services all of the time if we don't have our staff and our people on board. So that's another reason why things were quite challenging. And a resolution, unfortunately, is outside of our hands and needs to be dealt with by people outside of this room. And I would urge them to do that as a matter of significant importance. There have been a range of really brilliant things happen this year. And you'd be forgiven for thinking that wasn't possible if you just stuck to reading the newspaper or think pieces. But in the annual report, you can see that progress, despite all the challenges, substantial progress was made on reducing and eliminating very long waiters. That our prioritisation of cancer continued to make sure that we were reducing the backlog for cancer treatments and delivering just about or delivering the standards in cancer services. And that in a range of services we were implementing changes which join up care and deliver better outcomes for people. And the last thing I'll say about the annual report is it does reflect something that I think everyone around the table understands, and something we all firmly believe in, that the organisation and the system is made of people. It's the people that we work with, it's the people who deliver care, it's the people who they deliver care to. As we heard this morning, it's the peer support from people who have the same issue as you in our communities that really drive improvements in healthcare and keep people well. And our people plan as fundamental to delivering safe services, high quality services, financial balance, and meeting our 4 statutory responsibilities as money. And we need to continue to see that. So that was what I wanted to say about the annual report and the accounts, and I'm going to hand over, I think, to Bear for now.
Is it on? Oh, yeah. Hello. Hello, my name is Beverly Geary. I'm Director of Nursing for West Yorkshire ICB. I'm just going to share with you a couple of things. I'm going to repeat some of the things that you've said, actually, Rob, through a quality lens as opposed to a performance lens. And also, if we think about impact on patients, I'd ask people to think about that while I talk about cancer and industrial action, etc. So I think in terms of our achievements from a quality and safety perspective, West Yorkshire remains one of the best performing systems on progress to improve access to cancer services. And that's, recovering from backlogs that were caused by the pandemic. Our 28-day faster diagnosis standard, we're achieving 78% against a standard of 75%. As a system, our 31-day first treatment standard, we're achieving 94% against a 96% standard, but Airedale and CHFT are exceeding this. So that's really good news for patients. In terms of our 62 referral to treatment standard, we're achieving 68%. The expectation is that we'll achieve 70% by March 24, which, given that demand is increased by 8%, again, that's really good news for patients. So as I've said, we are one of the best performing ICBs in the country, and that's to be celebrated for our patients at these times. I'm going to go back to winter, even though we are going to talk about winter this afternoon. And as Rob said, we've been planning for winter since March, so we're barely out of last winter, which, as Rob said, was probably the worst that we've ever experienced in the NHS, certainly in my experience. And what I want to say that as a system, we managed the unprecedented demand and avoided any declaration of major incident and any adverse harm to patients as a result of the EPRR arrangements and our system ways of working. So people in all organisations across West Yorkshire and the ICB came together to ensure that our patients were safe and well cared for in this really, really difficult time. And we hope to take some of the learning from last year and bring it into next winter, whilst praying that it won't be as bad as the last one. In addition, again, as Rob said, we've seen some real challenges in relation to strike action, not just for patients and cancellations of appointments, but also for our teams in provider organisations and also at system level. And again, through our really good ways of working in West Yorkshire and via our EPRR arrangements, we've successfully managed these without incident thus far. And going forward, we're going to be one of 5 systems in the country to look at potential harm for patients that have been experiencing longer waits. So I'm sure that at the future board meetings we'll be bringing some of those findings back. But that's a national piece of work that we've been invited to participate in. Finally, and I think given that this is, we talk about maternity services a lot. I am privileged to be part of the LNMS, so the local neonatal and midwifery system. And we've been working in a really difficult context over the last 12 to 18 months, maybe even longer than that. And that's on the back of the Donna Ockenden report and also the Bill Kirkup report. And our LNMS have come together to share best practice. And we've seen some really positive results. And our CQC ratings for some of our services a testament to that hard work, where we've seen an increase in ratings of safe in some of our organisations and also well-led. We are not resting on our laurels, however. We've got peer reviews that are planned in the coming months. So November and December, every one of our our maternity units will be visited by a delegation of professionals from across the system to offer support, peer learning and challenge to ensure that our safe systems of working and our safe services continue. I'm going to leave it there, Chair, for the moment. Thank you.
Thank you very much. That's an incredibly helpful update. As part of our standard annual general meeting, we'll hear now from our Director of Finance, which relates to our annual report, which I mentioned earlier is online alongside our accounts. So, Jonathan, over to you.
Thank you, Chair. So I'm Jonathan Webb, Director of Finance. I just want to give a brief overview of the first set of accounts for the ICB. which covers the period from 1st of July 2022 to the 31st of March 2023. What's always been really important in West Yorkshire, indeed for this board, is that we look at financial position both for the ICB and also for the system. So in lay language, what that means is looking at the ICB's position for the statutory organisation plus the 10 NHS providers based in West Yorkshire. So we've got the ICB position and the ICS position. For the ICB, we started the year with a plan to deliver a surplus of £4.4 million. That's on a total annual allocation of £5 billion. That £4.4 million small surplus was matched with an equal and opposite deficit in provider plans. So as a system, we started the year with a balanced financial plan. So we were planning to spend all of the money allocated to us in West Yorkshire for the benefits of our population in West Yorkshire. The overall position that we finished the year with was a £0.8 million surplus across the system. 0.2 of that sat in the ICB and the balance sat in providers. Clearly £0.8 million is an awful lot of money, but it does need to be set in the context of an overall allocation of £5 billion. In terms of the ICB itself, we met our 3 statutory duties. So we didn't breach our revenue resource limit. We also managed our capital expenditure within nationally prescribed limits, and we didn't exceed our expenditure on running costs. So those 3 statutory duties that we met. We also produced a set of accounts that were deemed as unqualified by our external auditors, i.e. a clean set of accounts. And we also obtained, in our first year as an ICB, a positive value for money opinion from the external auditors, which suggests that we are spending our resources in a way that maximises the benefit for our patients and our population. In this slide pack that I think is available on the website, there's further information about where the money in West Yorkshire goes across our various programme areas, which some colleagues may find useful to look at. So the slide packs will be on the website. There is also more of a summary narrative about our financial performance in the year contained in the annual report, and the full set of accounts are also available as part of that document. Thank you.
Thank you very much, Jonathan. And we know a point from Rob earlier is that we have 9 months of accounts just due to the nature of the way in which we were set up under the Health and Care Act last year. Okay. Colleagues, thank you so much for those overviews. It's really, really welcomed. I think we're very proud of what we've achieved in the last 9 to 12 months as a board, as a senior team, as a partnership board. And thank you to Rob and senior leaders for making this happen. It's been a huge amount of work and it's been a challenging year. And we're about to go into another one, aren't we? Rob, we just wanted to invite you to give some reflections on the year ahead. I think you've started to hint at that. And for board colleagues around the table for the rest of the afternoon, we'll be coming back to this and making sure we've got foresight. But I think for members of the public and anyone watching online, I think it'd be helpful to hear from you.
Thank you. So in terms of the year ahead, it's worth reflecting on a few things which are real and present and will be in discussion about in the board this afternoon, and we've been in discussion about every board meeting, I think. And as an organisation supporting the system, we deal with things on a daily basis. You know, James is back in the room now, but he's just been dealing with daily operational matters. But we also have the privilege of looking to the future, because we've got to, because we can't be in this position all of the time in terms of the way that services are delivering today. We've heard this morning in our structured engagement session of some of the changes that are required to bring together mental, physical and social support for people in our communities, for example. So this year, I think we've got to recognise that the context continues to require us to be agile and to act. So the last few weeks, we've had 2 very shocking things happen. So we've had a serial killer operating in the health system who's been prosecuted, where the prosecution and the trial and the verdict has opened up a significant and substantial conversation about the culture in the NHS and the culture of speaking up and the culture of safety. We've also had an equally shocking piece of research which suggests that women in surgery are subject to, 2/3 of women in surgery are subject to sexual harassment in 2023, which is disgraceful. And these revelations are the kind of things which come along we have to respond to. It's easy to react to, but we have to respond to in a thoughtful and impactful way so that we have the right culture where people feel they can speak up, where issues get addressed when they're raised, where people are thanked for raising concerns, which is what we espouse. And we have to look at ourselves and see, is that the reality for people right across the system? And where we collectively ask ourselves questions about what does the sexual harassment in surgery say about the rest of the system? Is it the only place, or is it happening in other places too? And we need to make sure that we're addressing those. So that kind of context does shape what we do. It also is part of a broader context, which includes, the continuation of the cost of living crisis, the continuation of living with COVID-19, and the continuation of the need to address substantial inequity and inequality in each of our communities. So for the year ahead, we've got slightly changing context, but our priorities remain. And the great thing about this year is we've taken the opportunity to refresh our strategy. We've done that with people from right across West Yorkshire at all levels, engaging and co-producing something which will set our trajectory for the next 5 years. We've backed that with a joint forward plan that says it's all right to have a 5-year look, but we need to make progress. Real change happens in real work. So these are the things we will prioritise. And we will continue to focus on our 10 big ambitions around healthy life expectancy, the life expectancy of people with mental illness and a learning disability, supporting children in poverty, early detection of cancer, suicide prevention, antimicrobial resistance, maternal mortality, having a representative leadership, making sure our contribution to the economy is understood, and doing something about climate change. At the same time, there are national priorities which are the same as local priorities. People want to see their GP. There are national standards around that. People want to be seen quickly in A&E. There are national standards around that. People want access to a dentistry. There aren't any national standards for that, so we've created some. We need to focus on those things too, and we will. And as we go into winter, I think we're incredibly well prepared. As I said earlier, we're hoping for an end to the industrial action, which brings greater risk to patients and greater moral injury to our staff. Because without an end to that, things will be even more difficult. So I'm happy and content, I think, that we are doing the right kind of work together in the coming months. I must also reflect that our organisation, I started with structure, I should end with structure, even though it's not the thing that makes the difference to delivery. Our organisation is going through a substantial restructuring on the back of the requirement to reduce running costs by 30%. We start our consultation with our staff on the 26th of September, which will lead to a number of reductions in posts, and we're trying to make sure it doesn't distract us from the work that we've got to do, which is aimed at delivering improved outcomes for local people. Thank you.
Thank you very much, Rob. So that brings to a close our annual general meeting. We haven't had any questions from members of the public submitted in advance. If members of the public do have any specific questions in relation to the AGM and the documents online, please contact us through our corporate governance team and we'll provide a response. And in about 5-10 minutes time, we'll then move into our board meeting in public. And we do have some questions that have been submitted in advance that we can then provide responses to. And Shelley, your question is noted and we will provide a response to you. Thank you. Shelley, let me just finish the meeting and then I'll come back to you in a moment. Thank you. So, colleagues, that is the end of our annual general meeting. Thank you for everyone here who's gathered today in Bradford. We appreciate it to reflect on the last 12 months. We are now going to bring that meeting to a close and we will come back together at around, let's say, 1:15. 1:10, Laura corrects me, to then start our November board meeting in public. Thank you very much, everybody. Thank you. Good afternoon. Welcome to our NHS West Yorkshire Integrated Care Board meeting. We're here in Bradford today. Thank you to all my colleagues around the table for joining us today, and for our visitors, members of the public who have joined to observe the meeting in person today, and also to anyone who's watching live online or on record afterwards. We work hard within NHS West Yorkshire and our overall health and care partnership to be open and transparent in the work that we do together. My name's Cathy Elliott. I am Chair of NHS West Yorkshire Integrated Care Board, and I'm also Deputy Chair of our West Yorkshire Health and Care Partnership, and a warm welcome to everybody around the table today. As we have some people deputising, board colleagues, I know we do this from time to time, but I would really welcome you just doing a really quick introduction and your job title. For anyone watching the meeting in person or online, you can see the nameplates in front of you, in front of each person, but hopefully that's helpful. And just before we go around the table, I want to welcome our colleagues from Mental Health Services, Therese Patton and Keir Shilliker, who are joining us today for our focus on topic, which I'll come on to in a moment. Therese, would you start us off, actually? Welcome.
Oh, I've failed on pressing the button. Oh, okay. My name's Therese Patton. I'm Chief Executive of Bradford District Care Trust, which is the mental health and community trust provider in Bradford and Craven District.
Hi everyone, my name's Keir. I'm the Programme Director for Mental Health, Learning Disability and Autism across West Yorkshire.
Hello everyone, I'm Sarah Munro. Here is the Sector Lead for Mental Health, Learning Disability and Autism, and I'm the Chief Executive Lead in York Partnership Trust.
Hello everyone, I'm Mel Brown. I'm Director of System Reform and Integration. I'm also deputising for Joe Webster today as Deputy for Place Lead.
Hello everyone, I'm Jane Mashenko and I'm here on behalf of Health Watch and I'm deputising for Hannah Davies.
Hi everyone, I'm Ian Holmes, Director of Strategy and Partnerships for the ICB.
Hi everyone, I'm Kim Shuttler and I'm the Sector Lead for the Voluntary Community and Social Enterprise Sector.
Hello everyone, I'm Jane Madeley, I'm one of the non-exec members for the ICB.
Afternoon everybody, I'm Brendan Brown, I'm the Sector Lead for the 6 acute trusts across West Yorkshire and I'm the Chief Exec at Calderdale and Huddersfield.
Hi everyone, I'm Tim Riley, I'm the Place Lead for the City of Leeds, for the ICB.
Hello everyone, my name's Beverly Geary, I'm Director of Nursing for West Yorkshire ICB.
Hello everyone, I'm Majid Hussain, one of the non-exec members for the ICB.
Hi, I'm Stacey Fleming, I'm the Governance Manager and I'll be taking the minutes of today's meeting.
Hello everyone, I'm Laura Ellison, the Director of Corporate Affairs for the ICB.
I'm the Chief Executive of NHS West Yorkshire.
Hi, my name is Jonathan Webb. I'm Director of Finance.
Hello, I'm Anthony Keeley. I'm the NHS England Director for West Yorkshire.
Afternoon all, I'm Anash Chatterjee, one of the non-exec members on the ICB.
Hello, I'm Carol McKenna. I'm the Place Lead for Kirklees.
Hi everyone, my name's James Thomas, I'm the Medical Director for the ICB.
Hello, my name's Karen Jackson, I'm the Chief Exec at Locala, which is a social enterprise providing community services, and I'm the Sector Lead for Community Services on behalf of my community services colleagues.
Hi everyone, I'm Rachel Spencer-Henschel, I'm the Director of Public Health for Kirklees and I'm the Sector Lead representing the 5 Directors of Public Health across West Yorkshire.
Hello everyone, I'm Kate Sims, I'm the Director of People for the ICB.
Good afternoon all, I'm Becky Malby, I'm a non-executive member.
Hello, I'm Richard Vautry. I'm the Primary Medical Services Representative and a GP in Leeds.
Hi, I'm Mel Pickup and I'm Place Lead for Bradford District and Craven and Chief Exec of Bradford Teaching Hospitals.
Hello, I'm Harris Sultan. I'm on the next direct placement on the ICB.
Thank you very much, colleagues. I think that is really helpful. We'll just wait for another colleague to come back and join us. Richard, congratulations on being elected to the Royal College of GP's president role. I know it's a ceremonial role, as you say. I did ask you about what kind of comes with that, but there's lots of coverage in the sector press, particularly about your role and being elected to that, and congratulations. We're very pleased to have someone in West Yorkshire taking on such an eminent national role. So thank you for sharing that with us and congratulations. Robin, would you just introduce yourself? We've just gone around the table.
Apologies, I'm Robin Tuddenham. I'm the Place Accountable Lead for Calderdale and the Chief Exec of Calderdale Council as well.
Great. Thank you very much. So, as I said, we're here in Bradford today. Our November board meeting in public will focus on particularly mental health, learning disability and autism services. We have colleagues here today who are leaders within our system on that. There is a very comprehensive document in the public domain showing the work that is taking place on good practice and good services that are working and the quality improvement and innovation that is planned or is taking place. So we're going to hear later from Sarah, Keir and Therese. We also have winter planning on the agenda, and for those of you that were here for our AGM, our annual general meeting, we have been planning for winter since March, and we'll be hearing later about the plans going forward in line with NHS England requirements and our learning and plans together here in West Yorkshire. We'll also hear from colleagues on ensuring people are at the heart of our decision making 1 year on, and a thank to many colleagues who have been involved in that. Just for the record, but also to thank people, and some people are in the room as our visitors and guests today. We had a board engagement session this morning on looking at services for mental health, learning disabilities and autism. Thank you so much to colleagues from Healthwatch, West Yorkshire Voice Forum, and so many people who are still here with us. Thank you so much for staying with us, who have shared their stories, been candid, open, and one of my colleagues particularly talks about the generosity in sharing their stories and experiences with us so that we can understand what's working and also what needs to be improved upon. We're going to make sure that there is a record of that, as we usually do for our engagement sessions. That will go on our website and also will be shared with leaders around the table who are working in those services. But particularly a recognition from that session around ensuring mental, physical and social needs are understood together, working continually to ensure that we're a trauma-informed system, and making sure that there is local support in local communities. And I know colleagues will reference that session this morning into our discussions. Something I say at the beginning of each meeting, but I hope we manage to hit the mark each time, is around the 4 purposes of an integrated care system. All 42 in the country, including ourselves, are required to focus on reducing health inequalities, managing unwanted variations in care, using our collective resources wisely, and making sure that there are wider benefits of investing, and that's particularly around social and economic development. And you'll hear later about our developing work with West Yorkshire Combined Authority. So there's some highlights for you. For members of the public, all that documentation is available online to download and view, and you also have access to this meeting today via this recording. And as again, for colleagues and our visitors and guests today, this is a meeting in public. We do have some public questions we're going to come to in a moment, and any other questions we'll take in the breaks or after the meeting. So just as a matter of usual business, we're now going to go to item 3, which is the minutes of our last meeting in July when we were in Batley together. And particularly, I want to make sure that we have a sound record of that meeting. Laura, I will come back to declarations of interest in a moment. If we can just check that is a sound record of our meeting together that day in July. Yes. Yeah. Okay. We'll come on to the action log and matters arising in a moment, and I'm going to go back to the portal and the declarations of interest so I don't get into trouble with Laura. Does anyone have any declarations of interest in relation to today's agenda? Kim and then Jane.
Thanks, Chair. I'm also the Chief Executive of the Stella Trust, we're a mental health charity based in Bradford, and we're commissioned by the ICB.
Hi, and my day job is an executive role at the University of Leeds, and I'll probably ask some questions on behalf of students under item 6 as well, focus on mental health.
Thank you very much for proactively raising that. And what you can see on the agenda and you can see online is that we now have a mydeclarations.co.uk online portal where board members can keep their register of declarations of interest live. That is also a point for me all to remind you to keep them up to date as well. And thank you to the governance team for putting that together so we have got the most up-to-date information, which I know members of the public are very interested in seeing as well. Okay, Rob, sorry.
Sorry, Cathy, I was just going to draw attention to an indirect conflict of interest that I have, as my son is an ambassador for National MenCap.
Thank you very much, because your other job is being George's dad, we know. Thank you. Okay, so moving on to item 3 in the minutes of the last meeting, there's some points on matters arising. We'll come to those in a moment, but Laura, if you could just take us through the action log, please.
Thank you, I will. We've marked up quite a few this time as being proposed for closure because they are scheduled on today's agenda, so I won't talk through those. And we also have a small number that are not yet due. I think if I could just move everyone down to almost the bottom open action, which related to our focus on session last time around community services, and it's to do with the metrics to be captured in future integrated performance reports. Anthony's going to give an update on that. Thank you.
Yes, thanks, Laura. So we agreed a new format for the integrated performance report at the last meeting, and building on the discussion we had around community services last time, we agreed to, in future, incorporate a wider set of metrics to reflect how we're doing on delivering community services. So just to note that is progressing. We in fact incorporated an initial set of metrics into the report for the finance, investment and performance committees last meeting, and we're working through at the moment with the community provider collaborative what would be the most useful set of publicly available information to incorporate into the public performance report for this board. So by the time of the next meeting, we'd expect to have an agreed set that we can report on at that stage.
Thank you very much. And as colleagues remember, we met together in Batley to look at community services, all aspects of that across sectors and places. Thank you to Karen and many colleagues who were involved in that day. For any members of the public looking at documentation, particularly our performance dashboard, that includes NHS England required targets and metrics that we need to report on. But as a system and as a board here, we very much decided that day that we wanted to look further into community metrics to make sure that we can understand progress and ways of working. And I know also you're looking into children and young people's metrics as well beyond NHS England requirements, which is really welcomed. Okay, anything else on the action log? No. Thank you very much, Laura. We've got a couple of matters arising, which I just wanted to invite colleagues to share. One is and to invite Kate Sims just to give us an update on our influencing work on Agenda for Change uplift for non-NHS organisations. And then we've got 2 other points, one with Ian Holmes and one from James Thomas.
No, thank you, Chair. And just to refer back, I know we had a discussion at the last meeting around the matters relating to Agenda for Change equivalent pay for colleagues in some of our other organisations. As we said at the last meeting, we have raised this. I know other colleagues right across the country have, both regionally and nationally. That continues to be the same position, Cathy, that whilst matters have been raised, that there hasn't necessarily been a solution to this. So my suggestion would be that if you wish to close this down, but I make a commitment that certainly for colleagues like Karen and Kim et al, that I would continue to update them if these matters can progress. We have raised it recently.
Thank you, Kate.
Okay.
That's welcome.
Thank you.
I can see Karen nodding. We just wanted to come over to Ian now on an update on commissioning and resourcing around oral health and dentistry. Colleagues, you remember we met in May to look at this as we were a matter of weeks into taking on the commissioning for this, and we wanted to make sure we had a focus. Ian.
Yeah, thanks, Cathy. So we had a good conversation in May about the challenges facing dental services, and we agreed a high-level plan that would address those challenges over the short term and longer term. We're cracking on with that plan. We've come up with a detailed plan for investing the £6.5 million that the board agreed. We could go at risk to spend on the basis that it would be clawed back because there's not the sort of the core dental provision to deliver it. We're putting 4.9 million into additional urgent access schemes right across West Yorkshire. We're investing about 650,000 in access schemes for specific populations that we know are less well served by dental services, such as expanding the homeless scheme that started in Leeds across West Yorkshire, focusing on dental services for 0 to 5s in the most deprived 10% of communities in West Yorkshire, and providing services for gypsy and traveller communities as well. Working with Karen's team on the community dental services agenda. So these are services for people who might have autism or additional needs where core dental services aren't appropriate, and we're working to improve capacity around that, working with the Association of Acute Trusts as well, recognising that one of the barriers to that is theatre capacity. So we want to work collaboratively to try and create that capacity to provide those services. And we're working really closely with local authority partners on the prevention agenda, expanding out some of the schemes that you heard in May from Dr. Peter Day around, oral health improvement for people with autism and other groups of people. And on the prevention side, we're continuing the conversation with the Department of Health and Social Care around fluoridation, the appetite for fluoridation, working with partners across Yorkshire and Humber, and recognising that will be quite a long and complex process. The good news I've got from yesterday is that we've recruited to a new head of the team, so a full-time person who's going to be leading that programme of work across Yorkshire and Humber. We agreed in May that we need to put additional capacity into the team, so we've carried out that recruitment, and I'm very excited about that person joining in due course. So it feels like the right package of interventions, I suppose, but recognising, as we discussed in May, the challenges that we've got in dental are significant and long-standing. I think that's evidenced by the volume of complaints we've received on dental when we received the service in May, and the volume of complaints that we continue to receive as an ICB month on month around dental services. Working really hard to address that, improving the quality of responses. We've put additional capacity in to address the backlog, and we're developing our website to make it much more accessible to people so they can get better information on dental services through our website. So a lot of work happening in the dental space.
Great, thank you. And thank you, Ian, to you and other colleagues who've been working on this as well, because it is across our North Eastern Yorkshire region, as well as working with NHS England, as well as all our colleagues within our partnerships. Thank you for that. Rob?
Yeah, just wondered, Ian, if you wanted to say anything about the continued support from the local dental committees and how important that's been to the progress we want to make.
Yes, absolutely. We're building a really positive relationship, I think, with the local dental committees and through the West Yorkshire Local Dental Network. We shared the spending plan with the local dental network, and we've kind of co-produced it with that. That's a multidisciplinary group of dental providers across West Yorkshire. So there's a huge amount of enthusiasm and a huge amount of good ideas coming from that group. We need to turn that into reality in terms of the way we commission services.
Great, thank you. I think that's a really helpful update as we're a matter of months into being the Commissioner for these services. Richard?
Yeah, Cathy, following the meeting that we had last time, I met with a dental colleague around the issue of fluoridation. I mean, you mentioned it in your report, and our discussion with them as well. Clearly, one of our aims is to address health inequalities, and one of the best ways that we can do that in terms of dental health is to pursue fluoridation across West Yorkshire and enable our residents to get access to that in the way that other parts of the country, particularly West Midlands and elsewhere, have had for many years. So I think pushing that, I think, is something that we really should do as a board, and I would hope that we'll continue to do that.
Thank you, Richard. And I've particularly asked our colleague Becky Mulby, who has a non-exec remit from Future Generations, to support the team with this as well. So this is something that crosses across our partnership, working with local authorities, voluntary community and social enterprise sector, and the breadth and depth of NHS, as well as for us as commissioners within NHS West Yorkshire. So Ian, we're going to ask for more at another point, but please keep us updated. Thank you. Just wanted to come on to James before we then move on to our public questions. James, as you know, we had a discussion at our last board meeting on learning from deaths. This is standard practice within the NHS, particularly making sure that there is learning each time, and that's an obvious thing to say. I wonder if you can give us an update, please, particularly on primary care as well as more generally for the system.
Yes, no, thanks, Chair. So as an ICB, we are committed to understanding the mortality data, the outcome and the outcomes specifically there. I think in terms of what happens across West Yorkshire, I know from discussions I've had with various our medical directors in our organisations that there is a thorough kind of assessment that's done within our organisations to understand some of those themes, understand some of the issues that we are seeing with some of the outcomes of mortality. We also understand in place that we have a place arrangements in order to be able to understand that. As well there. I do think, and with the development of the medical examiner going wider, so the medical examiner has been in place within our acute trusts for several years. It's now, the aim is legislation coming in next year that the medical examiner will also be looking across at deaths across the community and primary care. And over the last year, across West Yorkshire, we've brought together the medical examiners to look at some learning from that as we develop the services across our communities and across particularly primary care there. So actually from that, what we are looking to do is to build from the medical examiners, from our wider knowledge, a oversight group that looks at mortality for West Yorkshire. So we can bring in the learning from our organisations, bring in the learning from the medical examiners, bring in the learning from our places, and so we can share that learning, understand some of those themes there. That brings in also the any leader work there, also any of our Regulation 28s in terms of understanding some of the learning across any of those regulations there. And then that group will then feed into our system quality group, which will then feed into our quality committee there, which will then feed into the regional oversight and assurance mortality group, which feeds into the quality group at region there. So from a process point of view, I think that will help us and also help support understanding from region. But more importantly, what will enable us to do is to bring together those who have that understanding, have that input, have that awareness from our organisations, our places, to kind of share that learning and understand where there may be some themes that we need to address.
James, that's really helpful. And our colleagues, particularly on the non-exec side, as part of our quality committee, Majid and Becky, I think that's a really helpful thing to have foresight on as well. And I know, James, you've been part of work in our system for many years, wanting us to be clinically led, wanting us to be a learning system. So I think in this area, we're going beyond the basics of what's being required for us. I think this is really welcome. Thank you. That's great. Okay, so that's matters arising. But colleagues, thank you for those updates. I just really appreciate them. We're now going to move on to item 4, which are public questions. We've had 2 questions submitted in advance. One is from Jenny Shepherd, one is from Chrissy Parker. So, Laura, you're going to read them out for us. And then we've got responses. And then for Jenny and Chrissy, we'll provide a written response for you directly, as well as we will then post them on our website as well. So, Laura.
Thank you. I'll just do a summary, but we will put them in full on our website. So the first set of questions are from Jenny, and they relate to a number of AAA reports to the ICB board from the Quality Committee and the Calderdale and Kirklees Place committees, and relate to excess deaths. So the questions are, what progress have the Quality Committee and Place Leads made with an investigation into excess deaths? Where is the data on actual excess deaths on a local basis for the time period under investigation, which I believe is since spring 2022, and the causes of these deaths? And what action is the ICB taking as a result? If these investigations are not yet complete, when will they be? And I'm going to pass to Beverly to respond. Thank you.
Thanks. Excuse me. Thank you for that, Laura. And I think that specifically we're talking about ambulance turnaround times and things like that. So I'm going to give a point of clarity, and I'm also going to talk a little bit about serious incident oversight. So in terms of clarity, registered death data is prepared and reported at national level through the local authority public health directors, and annually this will include what is termed as excess death data. The monthly data received provides us with details of registered deaths. However, this does not include any ambulance-related data, so that's the first point. It's also important to note that even though supplied monthly, due to a time lag with death registrations, it looks at cases 9 to 12 months old. So I just wanted to make that point. Having said this, excess deaths data is a crude calculation based on weekly deaths versus a 5-year average for the same week. So using the period 2015 to 2019. And there will be nothing included in that data to suggest that there are any deaths direct as a result of a delay of an ambulance turnaround or waiting times in A&E departments. In terms of serious incident oversight and ambulance delays, this is a continuous process, both at individual organisation and place level and also at system level. If there are any concerns raised in relation to specific incidents or a particular case, a full multi-partner discussion would occur to review the process undertaken and to request any further assurances. We have Yorkshire Ambulance Service serious incident reports that come and have oversight by the quality, the quality oversight group I myself chair that. I report that into West Yorkshire Quality Committee, and also I meet at a regional level for the Executive Leadership Board that focuses on all aspects of service for Yorkshire Ambulance Service, but we also talk about quality. The last thing I want to say is, in recent months, we've seen some significant improvements in ambulance turnaround times, and also a reduction in incidents with harm. In August, we had no reported serious incidents in West Yorkshire from our ambulance service. And if we And the final thing I'd say is where there are organisations where there are long delays in ambulance turnaround times, there is a rapid improvement process work undertaken, and none of these are currently in West Yorkshire. They're in other parts of North Eastern Yorkshire. Thanks, Chair.
Thank you very much, Bev. And I think we're going to come back to ambulance services when we look at winter plan and performance. I know you and Rob have a role regionally as well in working with our colleagues at Yorkshire Ambulance Service, particularly as we're host for the service as well over in Wakefield. Thank you, Jenny, for the question. We'll provide a written response to you.
Delayed ambulance times that was to be carried out in the place committees of this integrated care board, and I was asking for an update on the work of those committees, and that has been completely missed by the question. So in the future I'd like to suggest that people are allowed to read their questions out to make sure that the full question goes to this board. Thank you.
Thank you very much, Jenny. Your full question has been received by colleagues around the table, and that was the response that Beverly has prepared for you. I'm sorry that you feel that way, and we will provide a full written response. And please talk to our colleagues who are here today in the break if you want to discuss further, but we'll provide a full response to you. I'd like to move on to the next question, and I think, Beverly, if you can then just take on board that point, and we'll go back through the detail as well, just to respect what Jenny has further shared with us today. Okay, thank you. Our next question is from Chrissy Parker, which, again, Laura will share in summary. That is not meaning that we are missing the detail of it, and I've seen the email discussions, and I've been part of colleague discussions in preparing to make sure that we're answering these as much as possible within the time we have in the meeting, and fully to the individual asking the question, and fully online afterwards as part of our public record. So our second question, Laura.
Thank you, yes. So the second set of questions have been received from Chrissy Parker. Again, I will just do a summary to give a little bit of the background and then go straight to the questions. So the questions relate to the Chief Executive's report to our board today, around where there is a comment around substantial risks on finance and quality, and also relate to a Health Services Journal article last week around the integrated care system's finances. So the specific questions, again in summary, are which West Yorkshire NHS organisations are being required to make the £350 million efficiency savings? What efficiencies does this require each NHS organisation to make? How are such efficiencies compatible with protecting patients' access to safe healthcare on the basis of clinical need? And what are the quality risks that are referred to in the report that follow from the financial risks and the efficiencies required to mitigate them? And if these efficiencies reduce patients' access to safe, timely, clinically needed healthcare and increase NHS clinical staff's burnout and moral injury, where does this leave doctors on the Integrated Care Board and its place committees in relation to the updated good medical practice guidance? And Jonathan's going to start the response and then pass to James. Thank you.
Okay, thanks, Chrissy. So just in terms of the financial aspect of this question, so in line with all other parts of the NHS, we're required by NHS England to deliver a level of efficiency through the financial planning guidance. And that means all 11 statutory organisations in West Yorkshire are part of that model, that system. These are required to ensure that as a system we can develop and deliver a balanced system financial plan. So that's one of the statutory duties we have both as an ICB, working with and alongside our 10 NHS provider organisations in West Yorkshire. As As I mentioned in the AGM meeting earlier this afternoon, the overall level of NHS revenue funding for the ICB is over £5 billion. So that £350 million level of plan saving equates to approximately 7%. The plan level across each organisation does differ, depending upon local circumstances, and there is further information provided in the performance report in the agenda pack today to set out how that relates to each of the 11 parts of the system. We do aim to ensure that these levels are both reasonable and deliverable, and we do that through organisational place and system review and ownership of plans, utilising our principles of peer review and mutual accountability. In all cases, when we're considering what actions we might take as organisations, places in the system, to ensure that any proposals, decisions are fully understood, each proposal is subject to an equality impact assessment that's led by clinicians in our organisations. And James, I think you're going to talk a little bit further about that process and what that looks like.
Yeah, no, thanks, Jonathan. Thanks, Chair. And thank you for the question there. So just carrying on from what Jonathan has said in terms of these efficiency savings are challenging. There's no doubt about that, and I wouldn't want to kind of minimise that in any way at all from the question at all there, and will be hard. But what I would say is, in terms of, as Jonathan said, there are processes in which we will take it through in terms of the quality impact assessment. But what I would also say is, and that happens both, I think that will happen in terms of those assessing these plans, assessing what we're planning to do, will happen in our organisations, it will happen across our places, and then it will happen across our system there. And at every point in that, in terms of running our organisations across our place and that system there, we have good, strong clinical leadership, and quality is at the heart of this. Quality has to be paramount in terms of our decision making there, and in order for that to happen, it's important that we have that clinical leadership from clinicians, not just doctors. I know it mentions doctors in the question, but not just doctors within those processes of assurance there, in order to be able to make sure that we are making the right decisions, that we are making sure quality is paramount there. Also, and that's quality of our services that we're delivering there, the quality and well-being of those service users, our patients there, and also the quality and well-being for our workforce. And what I would say is that there are, as in our organisations at our place, where there's significant change, and I appreciate that can sometimes be seen differently by different people, that we'll ensure that those processes are happening. But what is key is that clinicians are also part of those discussions as well. I'll probably end it there.
Thank you very much, and thank you for that question. We are going to come on to financial planning and delivery and risk and mitigations later on. Rob has been very open in his report, Jonathan has in his report, which is perhaps why people have also picked it up more broadly. We believe in being open and transparent. That's what we've done as a system and with NHS England on our financial situation. Okay. Thank you very much for those questions. Did you want to come back in, Rob?
Yeah, I think it's really important just to recognise that there's significant risk in the system. We all know that. We live with it every day. I mean, we've got frontline chief executives here. We've got people delivering clinical services. So James was working in practice on Monday as usual as a GP. So we know that there are issues and risks in the system. We operate constantly in a system that has to balance risk and opportunity and make good, sound investment decisions around the way that we deliver services. And as much as possible, we do that with people and make choices around that. The degree of risk, I think, is well reflected in the board assurance framework and the risk register. And people can see quite openly where we're saying there are risks. And, you know, the discussion we had this morning around mental health, learning disability, autism, and the discussion we're about to get into will, I'm sure, talk about risks that are inherent in the system due to delays in diagnosis for autism and ADHD and for access to mental health services for children. So I wouldn't want us to be in any way suggesting or being seen to suggest that there aren't risks in the system. And I would hope that's really clear from the way that we work. What's probably less clear, I think, is the process of equality and quality impact assessment that goes on. I know James has given a summary of that, but all of us around this table have been involved in those discussions to ensure that the impact of decisions, particularly where you're looking at efficiencies, are considered by people who are appropriately qualified.
Thank you very much. And just a reminder to visitors and guests today, as well as anyone watching online or keeping track of our work, our next meeting will be in November, and we invite questions by the 20th of November to be submitted in advance, and it gives an opportunity for colleagues around the table to give them 24 hours to prepare that response, or we'll receive them after the meeting and provide a response and put them on our website. Okay, that links then into our next item, item 5, which is looking at a 1 year on in setting up this board, making sure that we've got people at the heart of our decision making. I wonder if my colleague Karen Coleman might be available just to join us around the table as well, who is very much working with a number of people across the system on our new West Yorkshire Voice Forum and also our involvement framework for many years, and our non-exec colleague Becky Molby, who has been working on this with us for a year now. We are missing Hannah Davies from Health Watch, but we have Jane with us today to support us. So Becky and Karen, I don't know if you want to give us an overview. Everyone has read the document, and I'm really welcome that we can take a sort of 1 year review on where we're up to. Becky.
Thank you, Kathy. And thank you to colleagues who joined us this morning and to share some of their stories. So the reason why we took this approach is that I think it fits with the questions that some of you have asked us as a board, which is that sometimes it can feel a little bit impersonal, how we work, what we do, and yet we're all of us are carers. Rob and I, we're both carers. A lot of us have experience of the health service in West Yorkshire, very visceral experience. And we wanted to make sure that whenever we meet as a board, that we always keep, what I said is the end point in mind, people's lived experience absolutely in mind in every part of our decisions. So coming to the board, all the papers that you see here, local people will have been involved in them. When we talk about our mental health and learning disabilities and autism stories, you've got a whole public group that's involved both in Bradford, Therese, haven't you, Sarah, with the collective. We have West Yorkshire Voice. So every single piece of work that comes here has been done with local people, engaged and participating. And if any of the people who are here today want to join any of those forums, we would be absolutely delighted. It's so important, not only for you to be heard, but also to make sure that we are absolutely embedded in people's lived experience. So the important thing about the board here is this issue around variation, that we don't get in sort of a postcode lottery, that some people who get services get better than other people. That's the point of being West Yorkshire, is we try and make sure that everybody gets fair, universal health care. So we decided to run these sessions that some of our colleagues here today have been involved in at the beginning of the session, which is for us to just get ourselves centred and grounded in those real experiences as we come into the board. So not to negate all the processes of engagement before papers come here, but as we sit here, we can remember Paul's story, we can remember Claire's story, we can remember your story, Susanna, we can remember what you said as we talk about learning disability. It's right here, it's right central. So the point of the focus on sessions is for all of us to be fully grounded in people's experience as we come into these sessions, so that you understand that we really, really care about your health, and we really care about our health, and we really, really care about our own relatives' health. It's all of those. Now, what we've done is we've tried this for a year, so that in every session, Kathy, Rob, the team decide what are going to be these focus sessions, these things that matter to us. They might not be what NHS England tells us is a real big priority. It's what we think is a big priority. Children and young people's mental health and autism is a really big priority. We're talking about this during the session in a minute. So in order to do that, we have these sessions beforehand of anybody that's got experience who can join in with us and talk to us about it. So that's what we've been doing for a year, and this has been a chance for any comments back from colleagues on the board about how that's working for you, whether it's helped, whether it hasn't helped. The second thing that we asked, and we haven't as yet put in place, and it'd be good to hear from colleagues whether they think it's worthwhile, which is that and it was really helpful to hear that issue you were talking about, you were asking about the Quality Committee and harm, which is as we take particular issues on the performance report, and that can be about ambulance waits, or it can be about IAP services, or it can be about oncology, or it can be about cancer and how quickly people are getting cancer services, that we take lived experience into that too, so that we start telling a story or hearing stories, maybe for each of those times that we discuss the dashboard, we take one item of the dashboard and we go through people's lived experience of it. And I think that begins to perhaps play into, when you read the papers, you'll maybe then see more of how we are bringing those stories, those real experiences into our decision making. So we haven't got as far as that yet. We've been trying to get the dashboard right, because certainly the dashboard, the things we were asked to pay attention to weren't the things that we thought fully reflected everything that we think people in West Yorkshire care about. So we've been trying to get that right, whether it's GP access and the nuances of that, whether it's children and young people's mental health, whether it's community services. So we've been trying to get those metrics. You know, you'll know this if any of you have got kids, that you get more of what you pay attention to. So if you really focus on the tantrums, you get more of the tantrums. If you really focus on the great stuff, you get more of the great stuff. Rob's always doing that. What we look at really matters as a board. What we choose to measure and what we choose to focus on, and the stories we hear. So it's not just the data, it's people's lived experience with it. It really matters. So we've been really trying to get that right in a way that it reflects the population's experiences, our priorities, and NHS England as our funders and our masters, their priorities too. So that's the piece we've still got to do. And so this is an opportunity for members of the board to say, how's that working? Has it been a useful process? And is there anything more that we can be doing to bring that real experience of people into all of our decision making, so that people are truly at the heart of what we decide? Thanks very much.
Thank you very much, Becky. I think that's a wonderful summary of what we've been trying to do, so many of us together over the last 12 months. Karen, I don't know if you want to add anything particularly. I'd encourage you to make a plug for West Yorkshire Voice as well, particularly when we've got so many visitors today.
Afternoon, everybody. I'm Karen Coleman, very proud to work for the partnership, and I work in communications and engagement. So thank you, Chair. Yes, West Yorkshire Voice. Please get involved. It would be great if you would. West Yorkshire Voice aims to build on all the local community work that's going on to involve people in the local activity. Sorry, I'm used to talking to people, not mics. So it's a real great opportunity to get involved in the local work that's going on across West Yorkshire, and you'll have loads of local activity groups and involvement groups in our local neighbourhoods, and we really want to hear their voices and to build on the work that we do in our local places. So at West Yorkshire Voice, we've got over 100 members at the moment, 70 organisations involved, and most importantly that we need to be able to address the things that are important to this board, but most importantly the issues and the themes that are important to make sure our lives are as full and healthy as possible. So for example, we're setting up a dental reference group, because it's no secret that a lot of people are struggling to get NHS dental care, areas around access to primary care as well. So these are all the areas that we really want to address. So please get behind West Yorkshire Voice. It's not duplicating work that takes place in our local areas. It's absolutely building on people's voices, community voices, to make sure that that's at the heart of your decision making. So that's it. Thank you.
Thank you. Thank you very much, Karen and Becky and Hannah in her absence today. I don't know if anyone wants to share any reflections. We are, as you say, Becky, I was very keen that we had an engagement session before each board meeting. I'm keen to have these focus on sessions. So we really, I suppose some people call it a deep dive, but it's really making sure that we've got time as a board to get in and try and support our colleagues who are leading these services and are hearing from local people about the way in which they should be improved. And a great example we had today is Children and Young People's Mental Health Services in Bradford. The commissioning was absolutely led by young people, and I heard from young people who were telling me that, which was really good. Fatima, would you introduce yourself and welcome to the meeting as well?
Hello everyone, sorry I'm late. My name is Fatima Khanshah. I'm the West Yorkshire Inclusivity Champion. Firstly, I want to say how lucky we are that we've got people like Karen Coleman and Hannah and colleagues involved leading this really, really important work, because what's really impactful is the leadership and that ability to connect with individuals and empower them to shape services, and that is not an easy job. So thank you, Karen and colleagues. My reflections are just a couple, which is one, it's amazing to see the level of diversity and contributions of people on this agenda. But what I always hear now as the inclusivity champion and speaking to communities is there's always room for us to do more. So are there ways in which we can continue to reach individuals that feel like they have no voice in the decisions that we make, but also address some of the barriers that they have when it comes to contributing to these conversations? Practicalities like, for example, when we do them, how we do them, and whether we can contribute to things like caring costs, for example. The other thing that a few people have said, and I'm a chair of the Strategic Race Equality Network here in West Yorkshire, was the importance of being able to feed back how important these conversations are. So being privileged enough to be in this room and hearing these conversations and the action that's taken as a consequence, I feel quite privileged. And I know that we do a lot of work, Karen, don't we, sharing the work that this partnership does and how it improves the outcomes of communities. But I think certain individuals would really benefit from hearing the impact of those deep dive engagement conversations and what happens as a consequence of those meetings, because we do some really amazing work, but sometimes they don't reach everybody. And then the final one is, how do we continue to develop lived experience into the levers of people leading change? So I started my journey as a lived experience champion. I met a very, very insightful individual who gave me the opportunity to lead change, and I've not stopped since then. But I think it's really amazing that we're in a position where we're able to harness people's talents, but I worry that we're not able to continue to do so because of the focus on other activities and some of the challenges and barriers people experience. So as well as amplifying the lived experience, is there more we can do to develop that credibility and capability for people to lead the change?
Thank you, Fatima. I don't know, Karen, whether you just want to respond on that, and then maybe there's some more work that we can do, Fatima, as we take this forward. Karen.
Thank you, Chair. We had an opportunity to take an approach around citizens' panels that a lot of our areas do in other areas of England, but that didn't feel right for us. That was very much 9 till 5, if you can attend a meeting, if you can bob on a Teams call. So what we're trying to do around the West Yorkshire Voice is actually to go where people are, rather than them have to fit in with our agenda and our timescales. So what we'll be doing is we'll be doing weekend evening meetings. We'll be going out to local places, maybe children's centres when we're talking about children and young people, reaching people through the Maternity Voice partnerships, through our race equality networks, all of that, because it's really important that we've got diverse voice, really, and not typically what people might see, like myself, around the table. So thank you, Fatima, and as always, we'll continue to work together to make that a big success, I hope, for people and communities.
Great. And Fatima, one of my questions to Karen and colleagues was around asking people how they'd like to get involved. Is it about service redesign, innovation? I know all of our places are doing different kinds of things, like listening in Bradford District and Craven, for example. Some people like to come to our board meetings. Some people like to come to our engagement sessions. So I think it's understanding the interest that people have to take forward then. So we've got 2 other comments, and then we'll move on to the next item. Kim, then Majid.
Thank you. Thanks for the paper, Becky and colleagues. I found all the engagement sessions fantastic. I think the people have been, they've been humbling. The people have been really incredibly brave and generous in sharing their stories. The reason why I like being part of this system is I think we're always striving to be better, and I wonder whether the way that we can be better is being really pushing ourselves when people are telling us something needs to change, and having a really in-depth conversation, whether it's here or wherever it needs to be had, about whether we can change those things. So we've heard things this morning, which I know people will have been saying. You know, there's a brilliant young woman over there, Georgia, and saying to me what I hear all the time is, we've been saying these things to former iterations of this meeting for 10 years, 20 years. You know, where might we see that change? So I think, how do we translate those stories, which I know really hit us when we hear them, that, you know, people really listen, but then when we're making brave and difficult decisions, which we have to do, and perhaps those are decisions that might be against what the national guidance is, where are we having those hard conversations and then feeding back on that aspect? I think that would be our next step.
Thank you, Kim. And I think one of our tests is, if you remember back in November last year, we met people using GP services. We heard from them. That was timed at the same time as we were putting together the full delivery board. And Ian has agreed to bring our focus on topic for next time in November on primary care, particularly GP services. So I think that would be one of your tests. Hold that question for next time for Ian to see whether we are making change. But let's take that on board as well. So we've got Majid, Kate, Rob, and then we will move on to the next item. Majid.
Yeah, thank you very much, and thank you very much for the paper. Some really good sort of insights on the way we've sort of progressed on this journey, listening to patient stories before we engage in a conversation about that topic has really been helpful. A couple of things. I think that this point about you said, we did is really important, and for us to do that systematically so we capture what people have said, have a bit of an audit trail of where it went and what happened with it, and if nothing happened, why didn't it happen, or when it's going to happen at a later stage. The thing I want to speak about is the recommendation 7.2, which speaks about using citizen stories within the committees. I think that would be extremely helpful if you could do that, where at every committee we have some real examples of it. Have this service, this is what the data tells us, but what is the real impact on people, give some experiences, and then use that to build the actions and action plans going forward. So really welcome that recommendation particularly.
Thank you. Kate, then Rob.
No, thank you. Just to say again, Becky, what really welcome the report, and it's really interesting to hear that feedback around the session so far. It would not go without saying, obviously, as the Director of People, the title People at the Heart of ICB Decision Making, and I welcome the reference to moving it forward to risk focus, how we build in the workforce as voices within the communities, both as community members, but obviously as members of our workforce. We know there are a number of significant workforce risks across all of our sectors in terms of across the country, and I'd really welcome how we can ensure that as part of the people voice that the workforce is included in that. So thank you.
Great. Thank you, Kate. And you led a session for us, as colleagues remember, in January, where we were looking at workforce, and we met people from different sectors and different parts of the workforce. So I think we've tried it out once. I think it was a really productive session, but how do we do more of that? Rob.
Yeah, thank you for the report. It's really good to see us reviewing what we said we'd do and seeing whether we've done it, which I think is really valuable. I fully endorse the 5 recommendations. I've got some thoughts. So in terms of the you said we did, I think that would be a really positive thing to do. I do think we could have some really powerful examples. So we just talked about dentistry. So let's remind ourselves, why are we focusing on dentistry? Well, we heard from Health Watch and the public, and our experience of dentistry from the clinical voices in primary care and elsewhere was it was a massive problem facing communities. We had an in-depth conversation with people and staff about what we could possibly do about dentistry. We persuaded NHS England and others that we should go at risk with, what did you say earlier, Ian, 6.5 million pounds worth of investment into dentistry, and in an era where we're cutting posts, we've grown the dental staff to deal with that, and we've agreed that as an integrated care partnership, and we've agreed that as an integrated care board, and we did that because of that conversation, because of that input, because of that insight. That isn't the case everywhere. So that's a really brilliant example. I think we've got others. So the third sector panel that feeds into our race equity work and has done for the last 4 years, 3 or 4 years, is another good example. But before we get too self-congratulatory, let's remember Kim's challenge, which people say, look, we've been saying this for years, you've known this for years, why aren't you doing something about it? So I do think we need to be able to say to people, this is what we heard, this is what we said we'd do, and this is what we've done. Yeah. We need to say to people, this is what we heard, we're not going to be able to do it. Yeah. Sometimes we just have to be honest. If we can't do something, we're going to have to tell people that we can't do it. And there will be examples of that. And we have to have people keep challenging us in meetings to say, look, you've said this. I don't see it yet where I am. You know, the Sheila test from Chapeltown when we launched the race equity work. So I think that the other thing I would like to see in the report is a recognition that the amount of time, effort, energy and the potential for there to be wearing on the people who contribute to these listening events is substantial. You know, we just had conversations with people saying, I've just relived with you some trauma and I've shared with you things I haven't shared with my family. That's wearing. So we need to put in place some supervision and support, I think, for people who contribute to make sure that they're helped and supported subsequently.
Right. Thank you, Rob. So there's lots of nods around the table, and I appreciate it as well, particularly when people are sharing traumatic experiences in mental health services. So I think we've got a number of things there. I know we do, you said, we heard, and what we're doing next. Karen, you've been supporting me doing that, which was a point of learning halfway through the year from our engagement sessions, and that's what we're going to do today from the mental health. I ask those who are chairing ICB committees, particularly place committees, as well as quality committee, for example, and finance committee, on how you build in those stories of lived experience, and also, Anthony, whether we can work with you then on how we bring voices into and lived experience into the dashboard, and how we bring those two worlds together alongside Healthwatch intelligence, which we've been using for many years, and their new database development, I think, is really welcomed as well. And just to note, if you're not aware, we do invite Healthwatch to share their intelligence through our partnership board as well. Okay. Thank you, colleagues. I think Becky, Karen, Hannah, and I've been part of your working group for 12 months as well. So I think it's just taking on board these points, moving forward and seeing what's next for us as well. But thank you to everyone around the table who's contributed, people here today, and there are so many other people we've met along the way in setting up the board over the last few years. And I'm so pleased we've gone beyond a patient story at the beginning of a board meeting. We're going to do better than that. Okay. Thank you, Becky. That's great. Thank you. Okay, we're going to move on now to our focus on topic. Thank you, Karen. This is, as you know, we've been trialling this format for 12 months now in our meetings in public that happen every 2 months. Our focus on topic today is around mental health, learning disabilities and autism. Kieran, Sarah, I know you've been working on this for months, and I've been profiling it for a few months as well. Therese, I'm really grateful to you for also joining us as well, and you're all part of a West Yorkshire provider collaborative for mental health, learning disability and autism services. Colleagues, you know, around the table, every time we've had one of our meetings and engagement sessions since last year, mental health services and the improvement and improved access and better connectivity has been a repeated story. And you can see in our risk register, particularly around mental health and neurodiversity, including the increased demand for certain services, including in children, young people and mental health. So when we pick these topics, we don't pick them lightly. They are always linked with risk, but also wishing to showcase good practice and bring people together. You're an incredibly influential group of people here today, so hopefully we can make some decisions together like we did last time for community services. So Sarah and Keir and Therese, if you would give us an overview, I invite you to post some questions to us. This is a board meeting in public. We always have to be professional and fact-checked, but I would invite you to request support from the board as well as encourage a debate today. So over to you. Thank you.
Thank you very much, Cathy, and thank you for the opportunity. Mental health, learning disability and neurodiversity comes up at every meeting, so to have the opportunity to go into detail is really welcome. I'll also say we're not going to make any promises that we can answer all of the questions that have come up during the course of this board or over the last 12 months, nor do we have the solutions. Nor do I expect that this board in itself will have the solutions to the challenges that we face within our sector. I think the paper, just if you look at the length, but then the amount of detail in it, gives you an indication of the breadth and the depth of the work that we do as a collaborative. And I use the word collaborative in a loose term because there are some aspects of our governance that are very formal in terms of provider collaboratives under the auspices of devolved commissioning from NHS England. But I'd say that's a very small component of the work that we do. And through the work of the programme board, it's much more diverse in terms of absolutely having service users and lived experience at the heart of what we do, and that being part and parcel of the way that we've developed our programmes over the years. And also that breadth of sector in terms of VCSE being equal partners. As many things as you'll see in the paper that are our priorities, there's probably a list twice as long of where we've had to step away from things as well in terms of capacity and being really honest and realistic about what is achievable for us. So I'm not going to open those up to generate another list, but it becomes part and parcel of how do we keep focused on the areas that we can make the biggest difference. And if I was to say that there are 3 challenges, and then Key can talk some more of the detail of this, and I think it ties into some of the lived experience stories that we shared this morning. Through the eyes of a regulatory, performance-managed contractual system, you can't actually capture the demand that comes through in terms of the need of people with mental health needs or people from neurodiverse communities and what they need from our services. And therefore, you can't simply quantify what the outcomes can be. And we live in a world which increasingly has become focused on short-term outcomes as opposed to long-term support that people need to lead well, meaningful lives in their communities. So getting that balance between what we're required to do but what is absolutely the best thing for our service users is an ongoing part of the conversation that we have openly at our programme board. And areas where we push back based on the experience of service users is the recent one of the pushback on the national policy on NHS 111 as the single route into crisis services, and a national policy which would have required us to turn off other crisis lines so that the only way you could access crisis services is through 111. Now, none of us were of the view that it's wrong to be able to ring 111, but we know from our communities having safe, trusted access to local services takes years to build up, so we didn't want to lose that. So we as a programme board discussed it, agreed as a consensus to push back at national policy, and I've had that confirmed now that that policy will change. And that is about taking the strength of the impact for service users and the leverage that we have through the strength of this ICB to be able to influence. And the other area, which is workforce. We have a significant workforce shortage, and that's been chronic and will continue for some years. And when we talked about finances, our sector gets looked at because we can forecast financial balance. That's not because we want to, but because we know that the slippage we've got in terms of ability to recruit offsets where we have significant cost pressures and things like out-of-area placements, inpatient costs and so on. So we're not spending money on the right things within our sector, and there are some areas within our sector that get no funding at all. Autism, ADHD being the examples that the board has touched on many times, and are all shared in our passion to raise the profile and be able to influence to do something about it. And the final comment I'll say before I hand over to Kia, which is really important, is the populations we serve are marginalised and disadvantaged and their voices aren't heard. But even within the totality of that population, there are voices that are more marginalised and hidden and not heard. So the work that we're trying to do around health inequalities, through bringing that towards our own programme board and what our actions are, is really trying to tackle the layering on of disadvantage and discrimination that occurs, in particular within our sector. That's it. I'll hand over to you, Kia.
Thanks, Sarah. So yes, just a few things I thought I'd highlight from the report without going into the totality of it. I think just a few messages really. So the first one, so with things like the mental health investment standard, there has been investment into mental health services in recent times. It's helped to stem some, but certainly not all of that rising tide of demand. So actually when you kind of look at where we are compared to where we thought we would be when the long-term plan was created kind of 5 years ago, it's hard to see whether we've actually narrowed that gap between kind of mental health care and physical health care despite the investment because of the increased demand. And we do know, as Sarah's just touched on, that that investment absolutely does not cover neurodiversity. So the diagnostic base we've got for neurodiversity is not covered through mental health investment, and there is a big gap in capacity to do it. Sarah talked a little bit about kind of that juggling act we've got, about kind of how do we expand provision, but at the same time ensure that the quality of services that we have got, and actually it came out in the engagement sessions this morning as well. How do we hold on to people and wrap around people and make sure that we're not just presuming it's the end of their journey, because then we've got some more people to get through the door, and actually kind of from a service point of view, we've got to make sure we are helping people continually and not just letting them get to the end of their journey too soon. Within that, and the point that Sarah made around kind of diverse communities and how we make sure that we're focusing on those who need us the most, one of the big pleas I think for us as an ICB is that bit about intelligence and data and analytics. And you know, if our job is to make sure the resource gets to the right places, we need to know where and we need to know how to get the money there. And actually, when we look at how we work as an integrated care system, we need to create the infrastructure that allows us to make those decisions well, because we're not always confident that we do make those sophisticated decisions in the right way. And I think one thing to really focus on, which obviously does come up a lot and really legitimately, is that we need to be really clear about the impact on children and young people's mental health and the increased demand that's happened, particularly since the pandemic. But the fact that this is not just an issue for children and young people's mental health services, it can be, and they're a significant part of the solution and the answer. But actually, a lot of the support that's needed for young people is about their well-being, and it starts with family support. It starts with schools and education and local authority and health service provision wrapping around them not presuming the answer is always it's a problem for CAMHS. And so that's the thing about trying to harness the power of our integrated care system, not just the role of this particular integrated care board, which kind of links to Rob's point at the start, I think, in the AGM, particularly about the integrated bit and the fact that this is where we can get the value of the conversation, really. And we need those conversations at system, but they have to be happening in places as well. So what are those relationships between local authorities, education and the health services to wrap around young people in particular? Because if we don't, then we know what the impact is on adult services as well, and we need to make sure we've got some resilience and are supporting young people who've been through an awful lot of trauma. That'll stop. Yeah.
Thank you. Therese, I don't know if you want to add anything.
Thank you, Cathy. So the other thing I would add that we haven't mentioned so far in this piece is the estate. And it's very timely. This morning I wasn't here. The Yorkshire and Humber chief execs were having a meeting with Geraldine Strathdy, who's done a national piece of work on patient safety and mental health. And she talked really strongly about the impact of the environment on the mental health and well-being of our inpatients. She also talked about data and digital solutions, actually, which is something that we need to follow up. So she has real evidence now of how the environment in an inpatient mental health setting can have a really negative impact on the outcomes for our patients. And in Bradford here, not very far away, we have Linfield Mount. It was built in the 1950s, designed in the 1950s. And if you think about what mental health looked like in the 1950s, it was more about containment and management rather than therapeutics. And we've had lots of support from this board around the rebuild of that facility. We've got some adult wards in there. We've got a psychiatric intensive care unit in there. We've got a low secure service in there. And when you go into those environments, for those of you who haven't been in a mental health unit, you can stay for 3 months, for 6 months, for a year, for in excess of that, depending on your illness at the time. And in Linfield Mount, we have shared toilet facilities, 25 ladies, for example, sharing toilet facilities. We have, every day, we have sewage issues, sewage coming through the floor. We have no therapeutic space at all. We have very little access to outside space. And we've been talking really hard with the board, who are very keen listeners, and others around the importance of valuing mental health inpatient facilities and estate as much as we value others. When you look at the new hospitals programme, the 48 new hospitals that are being built, very few of those are mental health. Most of them are acute facilities. And we feel really strongly that we haven't been given the parity of esteem that we need for mental health services. I've had conversations with Rob about this, which have been very helpful, and we've talked about how we can have a local solution. And what we're asking the ICB to do is to think really differently about how we might use a very small envelope of capital that we have in West Yorkshire. Cathy very helpfully introduced us to Lord Malcolm not that long ago in Leeds, and as a result of that, the policy director, Victoria Cave, came to Linfield Mount a couple of weeks ago with some policy directors who work at the Department of Health, and talked really strongly about how capital in the NHS needs to be thought about really differently if we're be able to do some strategic work rather than just that day-to-day maintenance. There was an article not long after that in the HSJ where she talked about lots of stuff that we talked about, for example, giving the ICB some strategic capital so you could make some decisions locally. We've had some conversations locally. I'm hoping they'll come to the ICB committee soon to see if we can be ahead of the curve. But the estate is really, really important in terms of mental health and how we can get our populations well so that they can get back to those healthy and well-lived lives.
Thank you very much. I think that's really helpful overview from you all. Therese, just for clarification, because I know we have a number of guest visitors here today. We've had questions before to our partnership board, for example, on capital issues. We talk a lot. We'll probably cover it today on capital issues. There's different money in different parts. And could you just clarify, particularly, I suppose, make sure we've got that in the minutes, that the new hospital programme is the money you're seeking and where that comes from, and the other money and the alternatives you're seeking? I just think that'd be helpful.
Thanks, Cathy. So the new hospital programme is national money. We had to bid. There was a lot more bids that went internationally than there were allocated. So 48 hospitals across the country were given money to build. You'll have known about the RAC hospitals. It's happened now in schools as well. So the concrete issue we've had. Locally, we've had Airedale, which has been given money through the National Hospitals Programme to rebuild because of the issues around concrete. But actually, if you look at the numbers of mental health facilities in that 48 that have been given, and I haven't got the numbers, but I will get them to you, that have been given national money, they are very few. I think it's about 2 or 3 out of the total 48. What we're asking is to look at differently. There isn't, apart from the new hospitals programme, there isn't another way that you can get resources to build hospitals, new hospitals. So we are looking at different opportunities. Our build feels quite modest. It's about £90 million, feels quite a small amount of money actually when compared to some of the bigger projects. And we're looking to see if we can do that in phases, look at some smaller amounts of money first so that we have a build on probably 40 million first, then we build up to the 90 million. And that possibly within the gift of some of our capital locally at West Yorkshire, but it's a big ask. And actually what we need to do, as Rob said, is balance the risk against the benefit of that investment. And my ask to the board here, I suppose today, because we've talked about patient safety, and one of the very good questions from the floor is, please don't forget the patient safety issues for people who are in closed environments for significant periods of time.
Great, thank you. And you raised that also with Lord Markham from Department of Health recently. Thank you. So I've got people... Oh, no, I... So, yeah, we'll take your points in the break, Shelley, but thank you for sharing that. And my colleague Karen will note that down. So I've got a list of people, board members who walk around the table. So I think we've got Fatima, then Rachel, then Harris. Let me get these all down before we go round. We'll do it in order as we go round. Richard, Becky, and then if... Oh, my goodness. Kim, and then we've got... Jane and then Jane. Okay, so let's start off. And this is the point of this meeting. We've got a good half an hour or so, board members around the table, questions for clarification, comments, and then I want us to move, as we did in the community service session, to see what we can make a decision together on today and what we can support our colleagues in the room on, as well as taking on board lived experiences we did this morning and people are sharing with us today as well. So, Fatima, to you first.
So I'll keep it brief because there's lots of people that want to come in. I mean, the first thing I wanted to say is a sincere thank you to you, Sarah and Kia, for your leadership on the work we've been doing together on the independent review of the impact of health inequalities impacting our racially marginalised communities and staff. Obviously, some of the outcomes of that are within the paper, with particularly referencing the cultural competence training. I suppose my question is, how do we ensure that we're able to make sure that the work that you're doing is making the impact it should? So how do we know it's making a difference? And how do we build on the principles that we've been talking about with the You Said We Did to share with communities the impact of these services and build that trust again, particularly within mental health services? The second thing is, and it really resonated with me, Keir, your point about working with the other sectors. I've just come, the reason I was late this morning is because I was with the Mayor launching a campaign about supporting young people, particularly women, who are encountering sexual harassment in society. And there were lots of people there from local government, from education, and I wondered whether we're making the best use of our partnerships. There's lots of opportunities for us to put across some key mental health low-level interventions with partners in education, etc. And I wanted to extend an opportunity with my role as the inclusivity champion to be that broker, working with Jen Connolly as well to see what further we can do to support you on that journey.
Great, thank you. We'll just take a couple of other comments, which the role of Jen Connolly, if anyone isn't aware, that's a joint role we have, an Associate Director of Public Health, working with West Yorkshire Combined Authority and the Mayor Tracy Braben and ourselves at NHS West Yorkshire. Public Health, it comes over to you quite well, Rachel, so over to you, and then we'll come over to you for comments, then we'll take another two. Rachel.
Thank you so much, and again, I echo Fatima's points. I think it's a really comprehensive paper. I think just a few points to make. I think one of the things that struck me about the paper was that we talk a lot about needs. And I actually think there's a language change here around focusing on assets that a lot of our neurodiverse communities and obviously people that do have mental health issues but actually make a positive contribution to society. So how can we flip that narrative? And I was just thinking about us as a system and our employability power and how we perhaps think about being a little bit more creative about using approaches like job carving, things through Project Search, which I know we've done in Kirklees and other places have, to try and see that as a kind of almost like part of a therapeutical pathway rather than it just being a clinical intervention, because I do think we've got a lot of that capacity within our system. I think the focus on co-production, we talked about it, obviously it was part of the engagement session earlier, but equally I think that that's going to be so important in getting the right interventions at the right time. I suppose my only kind of worry about the system is that quite a lot of the earlier identification of some of these issues depend on having universal services in terms of things as education. We've talked about Healthy Child Programme, etc. I think that the financial challenges that are facing the system and local authorities particularly mean that the risk is we'll end up being more targeted in those services, which risks the fact that we won't get to people as early as we need to be. So it's something as a system we need to be mindful of to make sure the universal services are still detecting what they need to detect earlier so that we can put that earlier intervention in and prevention, and obviously hope people get whatever support they need to meet the best outcomes that they have.
Great, thank you. So we've got some points there on impact of services, working with other sectors, employability power, focus on co-production and universal offer. I don't know if one of the three of you or all three of you want to take a response on that.
We'll do it between us. So firstly, to come back to Fatima's point, it probably cuts across as well. So one of the changes that Kia made in the team last year for us, employ Emma Pearce, who's our own consultant in public health, and that was to bring in expertise and skills to help us better understand, using data and intelligence, the populations that we serve, so that then we can track through the impact on the population we serve. So the latest piece of work we've been doing with NHS England on the expansion of perinatal provision and becoming the lead provider, so taking on the commissioning responsibility. And the whole basis of that is actually we've got some really focused areas on where we need to see improved access into specialist provision from a much more diverse community in terms of ethnicity and who currently uses it. So that's being built into the design of that service. And she's working with a number of our programmes, especially secondary care, because previously that data's not been there or we've not used it in a way that's intelligent. So early days, Fatima, but we're building that into the way that we work. In terms of the use of language, I think that's a really important point. The bit that's really hard, especially if we're talking about our communities of people that are waiting for diagnostics, they describe it as a need. Absolutely a need to get access to just the front door of services. And then what we don't have is that follow-on support. So once you've got the diagnosis, how do you learn to live with autism, and what adjustments can you make so that it isn't seen as a need or a disability, but it's part and parcel of who you are. So we have got, as a plug, the summit date is now set for the 4th of December, which came from a session I think we had at System Oversight and Assurance Group, to bring in that wider group of people that isn't just NHS or just isn't just local authority, who've got different resources to help us really think differently around our populations of people that are neurodiverse and how we can better ensure that they are integrated and included and not just be sat on a waiting list. Anything you want to add, Kia?
Yeah, so just a couple of things. The first one, picking up Fatima's point again about how do we ensure the work's had the impact, and thinking about the specifics of things like the cultural competency and humility training. So we're really, really clear that we need a really strong evaluation, so working with academic partners to get that evaluated, to understand what the impact's been for not just the people who receive the training, but the staff themselves in undertaking. Do they feel more confident? Is that the sort of thing that actually we should roll out further? It's a pilot at the minute, and it's a pilot that's gone a lot bigger than we thought it would. It was going to start with kind of 50 odd people, it's now around 600. But actually, what difference has that made to them as staff? And then Rachel's point again about thinking about the recruitment piece, you know, the project search stuff, or kind of actually how do we help people with neurodiversity into the workforce, or even things like individual placement and support, which is for people with severe mental illness. There is something about moving it away from them being niche projects, little projects, little things that we do pockets in, and actually going, there's a movement here, there's actually a full-scale thing we can do about how do we, as anchor institutions and as kind of support for the wider economy, make sure we're tapping into the resources we've got rather than being little pockets of projects, really.
Okay. Therese, I don't know if you want to...
Just going to pick up the piece around the schools and the universal offer. It's been something that our leader here in Bradford has been very focused on, rightly, and we've done a number of presentations to Wellbeing Board about the approach we're taking in Bradford and Craven. And what we see in the numbers, and I'm going to talk about Bradford now, is that we've got far too many young people in our specialist CAMs, and actually not as many as we should have in our sort of general universal offer in terms of what you can get when you're in school, but you're struggling with an issue. So we've done a lot of work over the summer. we're launching into schools in September a bit of a roadmap, a dossier, because quite a lot of the difficulty I understand from schools that they don't know where to access help when they need it. So there's a bit around having some people in schools for the children and young people who are a bit more needy, but also there's a bit around signposting to the right places. So we're doing a dossier, I suppose, for the term, that's being launched this month. Then we're going to work with schools over the next few months to actually look at what do you need in terms of the offer to support your young people in schools. We're going to go back to the Wellbeing Board to see if our leaders are happy with that direction of travel. But then there will be a comprehensive offer within schools that can direct you to low-level support if you need it, or managing yourself if you need it, or into specialist CAMs. But I think the real issue when we had a presentation to Wellbeing Board before the summer was, for those young people in schools, CAMS is not the answer if you have sort of low-level well-being. We try to differentiate between well-being and mental health. If you have well-being issues, which can be very difficult, the direction to travel for you is not into CAMS, because that's not the right place for you to get the support. So it's a big piece of work. Very happy to share when we've got that work further progressed.
Thank you. That's really helpful. So, and we heard a great example in Bradford District in Craven of Healthy Minds, and CAMS is part of that. It is not the only offer there. So we're going to take 3 board comments, and then we'll come back to you 3 there, and then we'll take another 3. So we've got Harris, Richard and Becky. Harris.
Thank you, Sarah and Keir, because it was a year ago we had our deep dive on children and young people, so it's great to see it come back. I've got 5 really quick points. On the psychiatry part, about the difficulty not being able to appoint the high speciality training post. Why is this the case, and does that now present an issue 10, 20 years down the line that there's going to be less people there, and how does this impact our population? On the inequalities part around mental health, Stonewall reports that half of LGBT people said they've experienced depression, and 1 in 8 of LGBT people aged 18 to 24 said they've attempted to take their own life in the past year. I had a quote from a young person that they said sometimes it's perceived standard that an LGBT person has a mental health condition. So how do we shift that culture, that it's standard for a specific community to be marginalised, stigmatised? And then secondly, you mentioned about culture. How are we looking at the intersectionality between like gender, LGBT, minority, ethnic communities, instead of using this one-size-fits-all model? I'm glad the point about schools was mentioned, because the NHS West Yorkshire Youth Collective event a year ago mentioned the over-medicalisation of mental health and talking about mental well-being. And one of the teachers said, well, if you give something to us, then we'll use it. So it's great to hear about the work going on in Bradford. And final thing, on the November event on the redesign of ADHD and autism services, how are we involving partners such as the AHSN to ensure like, future forward thinking and that innovation side? Thank you.
Okay, Harris, I've made a note of that, and I think colleagues have as well, so we'll come back to those points. Thank you. We're going to go over to Richard, then Becky, and then we'll come over to our colleagues in mental health. Richard.
Thank you, Chair, and thank you very much for the report. I think it covers some really important issues. I think we, though, shouldn't forget that a large number of mental health care is delivered in general practice, so that needs to be factored in, sort of, within our improvement of mental health care services. So investment in general practice and primary care-based services will help to improve mental health services across the piece, and I think so we need to recognise that. I think there's been a number of points that came across from this morning session, sort of, one of which was the issue of long-term care, when we see so many of our patients receive really helpful, useful, but short-term input, and then they need that long-term support, which often isn't there. And I think we need to recognise the need that many of our citizens do need longer-term support, and they end up yo-yoing between services sometimes, and we need to find ways of improving that. We also need to recognise that there's a lot of our patients who fall between the gaps. So we provide some excellent services, but all too often, as I heard just in my surgery this morning from a patient who said, I've spoken to this particular service, but they say they can't provide the need that I have, but there's nowhere else for me to go, and there was nowhere for me to refer that patient to. So I think we do need to recognise that sometimes our services need to be more flexible rather than rigid in terms of the patients that they provide, utilising the skills that they undoubtedly have as best as they're able to provide as much care as they can to some patients who may potentially fall outside of sort of, their commissioned remit. I'm really pleased to see that we're seeing some progress now on the autism and neurodiversity ADHD summit that is now planned for December. I really do hope that that will lead to some radical change. Again, from my surgery this morning, I had another patient, and this is an almost weekly occurrence now, seeking diagnosis around ADHD, seeking some support around that. Not only are they've now got a long waiting time for the local NHS services, we should also be aware that many of the right to choose services have closed to any future referrals. So there's nowhere to refer these patients to now, both locally or nationally. So I think there's a real issue to try and address that, recognising that we can't carry on doing what we're doing because it isn't working. We do need a radical change because many of our patients want the diagnosis not to being able to have medication and treatment, but they want to understand why they think and act in the way that they do, and that helps them in their workplace or job setting or elsewhere. So I think we do need to be as swift as we can in providing that diagnostic access, if at all possible. Thank you.
Thank you, Richard. And that was reiterated when we came to visit some of your colleagues in August as a non-exec team to hear about experiences within primary care, particularly that week. So thank you for reiterating that. Becky, to you, and then we'll go over to our colleagues.
Thanks very much. I think we absolutely have to have a redesign and a rethink. And this is a crisis. And my concern is that we persistently, you're saying so, we talk about it all the time, is how do we manage to wrestle national attention that this is a crisis. So when we look at waiting lists and waiting list provision, we report it around physical weights, the 62, the 78. We don't report it around mental health weights. I know we try and do this as a board, is how do we make that as visible and public as possible. We need the public behind us here to help support how really important this is to the public, because at the moment it doesn't feel like that nationally, and it really should. So it isn't just that we can advocate, but we need our public to advocate with their local councillors, with their MPs as well. We need to make a lot of noise about this. So the first thing is this is a crisis. I remember, Therese, when we visited Bradford, hearing from our CAMS professionals, head in hands about the doubling of their caseload. What was it, from 2.8 to 6,000 people with no extra staff? This is absolutely crucial, critical, vital, concerning. It's a real issue, and we need to get really, really emotional about it. So if we have that sort of caseload, and we know we cannot go on like this, and this is a new normal, it's not just something that happened post-pandemic, it isn't something that will go away next year, it's absolutely here to stay, then I guess I want some pace behind that. It's now December summit. It seems to be taking a long time for us to get together as a system to do that redesign. So can we be assured that we're going to really, really do something important here? And I guess that also feeds into the work we saw in Bradford, Therese, which is everybody's trying to do lots of stuff. Schools feels absolutely critical. When are we going to get that 100% coverage across the whole of West Yorkshire, not just in Bradford? Are we clear across West Yorkshire that we're in schools with our ambassadors, with our mental health services, with our third and voluntary sectors? So schools feels important. You've said it's important. Is there a work stream around schools? Are we going to make sure that we've got some consistency across West Yorkshire around this? Feels a really important first step, at least something that we can see and know works. Secondly, that we know that we're going to absolutely rely on a voluntary and community sector for this. We need masses of support from the voluntary community sector. We've committed as a board to funding that over the long term. We've asked in Kim's paper previously, Kim, that we were going to have some resilience in the voluntary community sector, which meant longer term funding by place. So, Kim, it would be really helpful to hear whether that's happening, and whether the voluntary community sector is getting the support, not just the money, the resilience in terms of longevity that it needed and asked for in order to do this work. We heard this morning from our colleagues, it isn't just about money, it is about redesign. It is about consistency and lack of variation. What we're seeing across our place is quite a lot of variation as these new models emerge, because we're trying really hard to do something with something really new. But how are we going to make sure that it's consistency, that people that live on the border of Kirklees and Caldesdale aren't experiencing something very different from the two places? So where are we going to get that consistency from? I think the poverty is a cause. Are we being really public and open about this? So what we're seeing in terms of our mental health crisis is partly linked to poverty, and I suppose really understanding that and making that very visible. And the last thing is that you ask for more money, and you ask for a left shift, Sarah, Keir, Therese. How much? So you're saying in here we need an increased investment, We need to consider disproportionately investing in CYP-MH services. It didn't say how much you need, where from, so it'd be really helpful to get some quantity behind that. So when disproportionate, is it some places are doing better at that than others? I don't have sight on that and I'd like it. Thank you very much.
Thank you, Becky. And Sarah, Kieran, Therese, we are making notes as we go along, so I know that you're only going to be able to address some of the points that colleagues have just raised. There was a lot there, but if you just want to sort of share some reflections now, and then I encourage you to come and revisit that with us.
Yeah, so thank you, Cathy. That's helpful because I'm mindful of time as well. So I'll just share a few specific responses and reflections and invite Kieran and Therese to do the same. Specifically on the psychiatry, that's not a new thing, Harris, in terms of the number of people that choose psychiatry. That was the Royal College campaign to increase those numbers. So what we do is within West Yorkshire, we do everything we can to be really supportive and engaging with all of our future psychiatry workforce. So there's a number of forums that we now support them with over the course of the year, and that's around strengthening their relationships whilst they're in training with us as NHS organisations. So when they have a choice for their consultant posts, that they're going to choose us. So we've held like career workshops and all sorts of things like that. So, so we do what we can in that regard. I think we'll come back to, in terms of some of the stuff you raised on intersectionality, as part of the work that we're doing around the cultural competency training and how we take that intersectionality lens to that rather than from different protected characteristics. I don't disagree with anything that you said, Richard, in terms of the gaps that we've got and what that means in terms of what you'll be seeing in primary care, and that's at the heart of community mental health transformation, is to remodel what that looks like. But that requires a whole system change of primary care and the IAPT offer and what happens within secondary mental health care. We spotted quite a while ago, in terms of long-term need, the real issue around people with severe and enduring mental illness and access to rehabilitation support, which is why it's one of our areas of creating a service that didn't exist previously to support people with rehabilitation so that they can live in the community and step down from often secure out-of-area placements. That's early days, but it's going in the right direction, and that is an example of a group with a voice that is never heard because they don't count in terms of being attractive to investment. Becky, I hear what you're saying about the crisis stuff. There's a danger that we create a bit too much of a rush if we're going to fix this problem quickly when it's so long-standing in terms of where it's come from. And a lot of our challenge is in freeing our current workforce up that are in those services to just have the headspace to think differently about what they're doing when they're just overwhelmed with demand. The summit we're hoping is about that broader set of people, specifically for autism and ADHD. That's not the wider CAMS issue, but it is that real wrestle of how do we create the right offer around our staff so that they just can step off the wheel and think differently around the interventions that we're doing. And I say we can't rush it because there's a danger that some people will have got an expectation of what they're going to get, and we might change what the offer is. And how do you take people with you that have been sat on that waiting list for 3 years and all of a sudden they think they're going to get close to the top and we've redesigned something new, which means that they're not going to get what they're expected. So that's all the stuff that we want to wrestle with as part of that area. And the money, I don't think it's money from it's not money from West Yorkshire, it's money that should be invested nationally. And as I keep saying to other forums, in particular my own Council of Governors, we all have the right to vote. And some of these things are political decisions around what gets invested in at a national level in the whole of the health and care sector. So I always use that as an opportunity to think wisely about who's offering what in their manifestos as to what we will see the next wave of commitment and funding will be to the whole of the health and care sector. And that's just, I'll get off my political soapbox.
Thank you. I don't care if you've got a quick point because I've got 7 other people who want to comment. So maybe if we just take another round because we're aiming to finish up this in about 5-10 minutes or so. So maybe if we just take another round of people. We have Kim. Kim, please, will you talk about peer support workers in a minute? One of my favourite things. We've got Jane Maindley and then Jane Mashenko. Then we'll go to Mel. Mel, we'd love to hear about what you're doing in Wakefield because I think it's about place exchanges. Then we'll go back to our colleagues. Then we have AC, Karen and Majid, and then we're going to have to take a break. But Stacey, I know you're taking notes, and I wonder just on this occasion whether we just draw out the notes from here. They might not be perfect, but then we can share them with colleagues to take forward, particularly into their summit that's planned. So, Kim, to you.
Thanks, Cathy. Brilliant paper, and and I know that you will know all these things, but I wanted to say this in terms of our role as a board. So, in the risk register at the top where it highlights the 2 risks, I think those aren't all our risks, really high risks, are they? So, the risk on the demand for children, young people services, the risk is in adult services as well, isn't it? And older people services. So, that might not be in our corporate risk register, but I think a number of us around this table see every day that the waiting list for adult services, out of area placements, etc., are very significant. So I think the board need to really understand that the risks are not just the ones on here, and that it is an, you know, I was talking about this with Rob. They are issues, not just risks, but the risk is that they continue to escalate. It does link to what Becky said in terms of the VCSE. Because there is a lot of risk and hidden demand that is sitting within the VCSE right now. Thousands and thousands of people who are being supported by the VCSE. We struggle to quantify that because some of that's funded from NHS and local authority colleagues, some isn't. But that is significant if those organisations or services fold, because the impact on capacity is significant. I do think some of the data that we collect or are asked to collect by NHS England hides some of the reality of the risk as well. So, for example, we might be asked to report on first contacts. There's a very different picture between first contact activity and the experiences that we've heard today from some of the people, and I hear every day from the people that we support, about you might have a quick call with somebody, that's your first contact. That is not the same as receiving a service. So I think, again, important if we're thinking about patient experience to acknowledge that in the data, that sometimes hides that. The ask in terms of investment, I think we should agree that it's an absolute minimum that we hit the mental health investment standard. I've seen data previously where you can benchmark against other areas of the country. I know other areas of the country have made the decision to invest above the mental health investment standard. Maybe that's something that we do need to consider. You know, and I think we should be cited on that in terms of where we benchmark. And then just lastly, linked to peer support and the vacancy factor. It's really sad hearing that vacancy money is being used on the wrong things when there are alternative solutions that could be fielded, I think. So it'd be really good to have conversations about that, where there is that vacancy factor. Because it breaks my heart to think of that money then being used to you know, for a deficit, when actually that could be used for direct delivery, but with an alternative, innovative model, for example, using peer support workforce, using the VCSE, because we do have those solutions. They might not be the solutions that are asked for by NHS England. That's why we'll have to be really brave as a system in saying we are going to use the money in that way.
Kim, thank you. It's all really helpful, and it's something that Brendan, who has just walked back in the room, and I particularly raised when we had a meeting with NHS England colleagues back in April about how you bring multidisciplinary teams and multi-agency teams together, and that includes peer support workers. We're going to come over Jane Madeley, then Jane Mashenko, then Mel over in Wakefield. So, Jane Madeley.
Thanks, Cathy. Yeah, I had mentioned earlier that I thought I'd ask a question on behalf of the kind of university population, the student population. So obviously, you know, the universities are, you know, got a significant population across all of our places, and often the students who are coming through are in that exact sort of, you know, transitioning from CAMS into adult. University teams are keen to support their students and have, you know, services that we try to provide, but there's no kind of reference to the scale of the demand in that area and how we might work, you know, as education providers as well in this space. We talk about the schools and then adult, and some sort of reflections on anything that we could do differently in terms of how we work together in that space. I know there are conversations, but it'd be good to sort of draw out some of that. One of the things that we hear or concerns us within the student body when we talk to our student union executive about support for students in this space would be, you know, they only get to those who come forward, and there are many students, and I'm sure children and adults, who don't even feel able to know how to come forward, and that outreach piece and the crisis that is sitting there again, I'm not sure within the plan sort of how much in terms of that outreach role can be built in. I also really appreciate the I think that this summit idea, even if it's focused in one area for now, being radical would be definitely something we need to do. I should have said also I probably have a declaration of interest as a mum and carer of a daughter who's just transitioned from CAMS and now into university, and the how we think about the sort of radical innovation that isn't sort of constrained initially by financing and funding, and start with kind of where we need to be and then work out how we plot our way in that direction, I think would be a good mindset to deploy when we have those conversations. I agree with much of what Richard said earlier in terms of the kind of cases and the extremity of what people are finding in terms of accessing services currently. Thanks.
Thank you, Jane. I really appreciate that. And it was a theme also that came out in our discussions today about making sure that we've got good connectivity between CAMS and adult services and people aren't falling through gaps or being lost. So thank you for sharing that. Jane Mashenko.
Is that on? Yes, sorry. Thank you, Kathy. I think a lot of people have said what I wanted to say, but I'm going to reiterate it succinctly, hopefully. First of all, I just wanted to kind of do a cheerlead for Becky's comments, completely support both the impact poverty has had and that we absolutely need to be loud about that. The pandemic definitely has exacerbated it, but poverty, the austerity measures have really impacted on our communities and our children and young people in particular. I think that the paper is excellently written. It is clear. It sets out the tremendous complexity of the system that you're having to deal with. It sets out the achievements, but it also is honest and transparent about the challenges. I had a previous life before. I'm currently here for Health Watch, but I had a previous life in the world of Children and Young People's Mental Health Commissioning. And I know and I recognise the achievements that have been made in services. I see we have dedicated crisis services, dedicated eating disorder services. We have the crisis line. We didn't have any of that before. We're having increasing numbers of mental health support teams going into schools, which is all fantastic. But it's disheartening to hear the same insight, to read the insight report from Health Watch, to be in the engagement session and hear the same issues about long waits, about not having person-centred care, about the stigma of coming forward and saying in schools that I need help. I absolutely fully support the need to think beyond service provision. So let's think about working with partners, let's think about going upstream and working to say how do we respond to what actually young people were saying on our table is they need relationships, they need people they can trust that they can go to locally. So yes, how can we hear that?
Thank you, Jane, and thank you for joining us today to represent Health Watch. I want to go over to Mel in Wakefield, and just in the interest of time, then we'll go to other board colleagues, AC, Karen and Majid, and then we'll come back for some final comments from you. So, Mel, over in Wakefield.
Thank you, Chair. I just wanted to just reflect on the conversation we had earlier about investment, and there's been a suggestion about do we focus on mental health investment standard, and my anxiety about that is there's a growing gap for neurodiversity services, and how do we therefore fill that gap, and is there any way we can think of creatively doing something like we did with dentistry by putting together a package of support that will help us? And I know the Autism Neurodiversity Summit, which I love a good summit, will have a look at what we can do, but I think unfortunately that waiting list will only grow if we can't invest in capacity to be able to support the growing monthly referrals that our GPs and other colleagues are receiving for neurodiverse services. Secondly, I just wanted to sort of share, I was listening to what Richard was saying earlier about the growing demand in general practice around supporting mental health, and it's really important we maximise the additional roles and reimbursement funding to be able to create mental health support workers. In Wakefield, we've just been able to successfully recruit 7 I know that's not enough to support all of our general practices, but that's something that we've worked really closely with South West Partnership Foundation Trust to be able to do that in partnership with the Mental Health Trust so that we're able to recruit those posts. Early days for that, but I think that's important that we need to have a focus on that. And the other thing I'll just sort of share is sometimes it's not new investment, it's doing something differently with already the money we're spending. I just want to share an example about something we bravely did in Wakefield around our complex care budget to invest in the Crofts, which is a therapeutic residential setting. And unfortunately, we did have some young people who were accessing therapeutic services in Wales and in Scotland, so we just worked together as partners. I say just, it took 2 years to work together to develop the sort of capital that we needed to be able to launch the Crofts, but it means that in Wakefield now we've got a therapeutic setting that really does ensure that our young people can thrive within the community that they're from, to be able to offer them some stability where they wouldn't meet Red Kite in terms of criteria. But we've seen some really fabulous outcomes for the young people that are accessing that service. And I just think about what we're spending out of area placements for our complex care budgets and how can we do that differently with our partners to really improve outcomes for young people. Thank you, Chair.
Thank you, Mel. And you're giving us a reminder of how we need to make sure that we're highlighting best practice in places, making sure that's been exchanged across places as well. And I do invite place leads with your place committee chairs and many of your members of place committees to take this topic into one of your next meetings. I think that'd be really welcomed. And I can see the deep dives going on, say, for example, on neurodiversity for some place committees, but maybe you'd like to take the whole topic. Okay, we're going to go over to AC, then Karen, then Majid. AC.
Thanks, Kathy. Conscious of time as well, but quickly summarizing a couple of things that I think I agree with what Becky started about saying about complete service design and supporting both Richard and Kim's view. As a system, I think something that we could start thinking about in terms of capital financial planning is looking at proposals to move from a very curative mindset to a preventative mindset and how we are balancing that. So I think some of the solutions that were shared as an offer from bringing primary care and community volunteer care services together as an overall service blueprint, something perhaps we can explore as a principle for sort of system financial planning strategies worth looking at. So that's a challenge to ourselves to start how can we design our processes to help colleagues think across the system when putting forward proposals. The second bit is some of the things in terms of providing headroom, and again, we have been actively conversing about what is the role of transformation in the system. So working closely with Ian and Becky, we are looking at whether that's something that we could start exploring using mental health, perhaps, and primary care, and how can we provide that headroom to Sarah and colleagues, where you don't have capacity to think about the system transformation, and can we act as a facilitator and integrator of some of the thinking. So look forward to that, and hoping forward that we will be working together and perhaps come up with some opportunities over the next 12 months.
Great, thank you. And there might be something there with the ICB Transformation Committee, with the West Yorkshire Mental Health, Learning Disability and Autism Provider Collaborative coming together. It's offering that headspace as well. Okay, thank you. And there's a principle around design and commissioning. And we heard about a commissioning example in Bradford, which they were led by lived experience, which then led to a different way of commissioning and offering services beyond CAMS. Okay, Karen, then Majid. Then we'll invite you to respond. Then I'm going to invite Rob. Then we're going to take a break. Okay, Karen.
Thank you, and I promise to be quick. It's interesting how we've been talking about the way we need to work with other sectors. We were talking about education, what have you. For me, I think we need to think about how we work between the collaboratives as well, and we've talked about this before. If I think about the number of people our community colleagues go and see in the place they live, and they can actually witness what's happening, we need to think about how we use, please, they're all going to run away now going, no, Karen said. I think we need to think about how we use that and how we use that to help as an asset. Similarly, in the acute sector, you know, we interface with people who have both physical and mental health conditions. So I think we have to think cross-sectionally about how we do this. And that discussion about how we use the pot we've got is really important, that relative risk discussion, because it's tight, it's going to be tight, whatever happens. So we've got to have those discussions of what is going to give us the return that's going to support people to live well and fulfilled lives and we might have to make some difficult choices, mightn't we? So I suppose there's an offer there to say that I know the Community Collaborative have talked with you, and we'd like to be in that space because we go into people's homes.
Thank you, Karen. I think I feel like this is coming together. A number of other people have suggested that we get all three of our, or even provider collaboratives together: community, acute, and mental health, learning disability, and autism. And Mel said she loves a summit. I think I've just suggested another one, but I think there's a way in which that using the time and resource effectively, please come together as you think is effective. Majid, to you.
Yeah, very, very quickly, just a couple of things. So the first one is around variations and inequalities. I'm really pleased to see in the report that you've got a section on that. But in terms of data and insights, there's a lot that gets measured and there's some that doesn't get measured. So particularly the work around the voluntary sector, it's not quantified. We can't see what the gaps, what we're missing, etc. So it'd be good to see some more on what we're doing around insights, what we're measuring, what's missing, etc. Second thing is the report talks about all the great things that we're doing, all the great things that we need to do, but we mustn't forget the basics. So this morning we met colleagues who spoke about information and communication not being effective, not being correct, etc. The Health Watch report also cites some of those issues. So I think why some of these challenges are going to cost money, they're going to take time. We mustn't forget those basics that we need to get right, and for them to be consistent.
Thank you, Majid. That's really, really welcomed. And I think that links then with comments from population on population health and using our public health colleagues wisely as well. Okay. I don't know if one of you, all of you would like to just respond on that. As I said, well, we've got notes. I've made some notes here that I can give you a summary. But what are your thoughts? Has this been helpful? Do you feel like we're here, we're backing you, and particularly to make the changes and improvements you want to?
Well, firstly, it is helpful. It's helpful as a platform. It's helpful to have the honest conversation, I think, as well, about the challenges, about what might be possible, and the timeframes of it. Recognising your point, Becky, about the crisis and stuff needs to be done now, but also the other bit about the complexity and some of this, particularly when you're talking about what money do we need. That's not just NHS money. That's investment in the round in well-being. That's a complex conversation we need to be able to have. So where do we push and where do we own what we can? I think this picks up Mel's point. Where can we shift what we do it differently with the money we've got from the ICB, but where do we need to influence and work with partners to go, hang on, there's a much bigger thing at play here in terms of well-being. And it links a bit to Majid's point at the end, I think, about we want more insight from the VCSC. So we want to know more about the impact we're having. We need the capacity and the capability and the infrastructure as a system, and the people who can help us do that. We can't get that with the resource we've got now. So that's what we need to try and focus on. What can we do as a system that gives us the opportunity to go, we're counting the wrong things, we're making the wrong decisions. That's what we really need from a system, I think.
Kid, thank you so much. I really appreciate that. And it's a similar thing that came out from our community services discussion about what are we measuring that's important and that we've got oversight on. So I really invite you. It's another job for Anthony, but it's how we develop that dashboard. It sits in the public domain, and as you all know, you all sit on this board and other boards, that it's a really useful tool to prompt discussion. And it's a point that you made earlier, Kim, about we need to move beyond the first contact, what's important to us. I really want to invite place committees and place leads to take this into your place committees, that discussion about how schools, local authorities, NHS and voluntary community and social enterprise sector can work together. And it's a point that everyone's got money, influence, resource, capacity in some way, even though budgets are tight and there are a number of challenges. I'd really, it's your point I think you made about investment in the round and how we look at well-being as well as mental health, how we look at prevention as well as we offer support and care. And we won't lose that point earlier, Therese, on estates, and also points that members of the public have made with us today, this morning as well, around what is a good environment to recover in. And there was something that I really took away from earlier, which was the recognition that mental health services are a lifetime experience. And so how do we offer long-term support? It was such a key thing. I'm just going to hand to Rob as Chief Exec just to share his reflections, and then we'll take a break.
Okay, so I think we should decide, Cathy, whether we're going to agree the recommendations. I personally endorse all 11. I think we should agree the recommendations. In doing that, I've got a few comments to strengthen them further from what we've heard. and some things that we haven't. In doing so, I think I'm going to remind us of the context that we're in. So the points that have been made about poverty, 22% of people in West Yorkshire live in the lowest decile of deprivation. So if you average things out over the country, it should be 10%, it's 22%, but for children it's 28%. So if poverty impacts upon people, then it impacts upon children more. So we need to understand that, and we do understand that. Secondly, you'll all remember when COVID-19 struck, there was analysis that said there's 4 demand exacerbations that you're going to get, and they're going to come in a wave. So the first one is people will die of COVID. Second one is that people's treatment will be delayed by COVID. Third is people with long-term conditions will have their long-term condition exacerbated by COVID. And the fourth is mental health. Now, if you remember the shapes of the exacerbations, it went like that. Longer and higher on mental illness. That's what we're seeing now. And as Jane's pointed out, that wave was growing on something that was already growing for mental illness because of wider considerations. I think the other thing, the third point I would put in context is we've seen significant and substantial quality failures in mental health and learning disability and neurodiversity in the public sector and the private sector, which we have to address. So we shouldn't lose sight of those things, and I think the 11 recommendations help in that context. We shouldn't lose sight of the good stuff. You know, today, sitting here, and as a former chief exec of a provider of mental health services, it seems strange to me that we never used to have a specialist perinatal mental health service. What were we thinking? Or the expansion of IAPT, the really good performance on early intervention in psychosis, the 24/7 cover in our A&E departments, and so on. But we've got those things now, so we have seen some improvements. I think in terms of the 11 recommendations, I think they'd be stronger with a number of actions. So the first one is that Jonathan and colleagues are bringing forward a medium-term financial plan, because if we only focus on the day-to-day, we're always going to be in crisis. What we're doing over the next 2, 3, 4 years around investment, that should address the questions in this paper around the mental health investment standard and whether we can bring together some investments around neurodiversity and what that would look like, what the choices would be. It should also address the capital question. Let's be honest, we've got £160 million a year of capital that we control, and then everything else we have to bid for if it's a big scheme. 90 million in that context is quite a significant chunk of money. We're already using some of that capital each year to underwrite some national developments which require some additional local support. There's a backlog maintenance problem in all our acute hospitals. Capital is a problem generally, and we'll have to make some tough decisions on that. And again, we should do that in the medium-term financial plan. I think the second point I would make is that I didn't see any references to creativity in health. We've got a National Centre for Creative Health outpost in West Yorkshire. We've got some fantastic work going on in Therese's Trust, Sarah's Trust, South West Yorkshire Partnership around creativity in health, recovery colleges, all the things that we know keep people well. And I think we could probably, in the context of Leeds 2023, Culturedale, Bradford City of Culture, the research we're doing into those things, have a much stronger focus and emphasis on creativity in health. The third link I would want to make in amplifying the recommendations links to what Karen said. I mean, you can go to Linfield Mount, you can go to Newton Lodge, you can go to the Poplars, you can go to all sorts of places where mental health services are provided, but that would be the minority of mental health services. Therese and Sarah run community organisations. Most of the care is delivered in the community by people keeping people well and at home. That means that the fuller board, the integration of services, needs to really bring mental health services into the consideration of what we're doing in ways which would meet Richard's challenge earlier around the role of general practice and would bring the community insights into the right sort of space. So I would want to see that much more strongly recommended in the recommendations or agreed. I think the fourth is that this really needs to be something which is part of everything we do as an integrated care system. So we shouldn't just only talk about mental health when we're talking about mental health. We're always talking about mental health because we're people and we have mental well-being and mental health. So I do want us to endorse the recommendations, and I do want to strengthen them further if that's possible. And we should make sure that our planning for next year takes into account all the recommendations. We continue to make progress.
Thank you very much, Rob. That's really, really helpful. So, colleagues, as you know, in your board document for item 6, we're being asked a number of things to note, support, prioritise, including continued commitment to prioritisation of the mental health investment standard, need for the new ICB operating model to strengthen capacity and capability, and data intelligence sharing, which is Keir particularly talked about, prioritising West Yorkshire resource, particularly around promotion of careers. We're looking at development of an inpatient strategy, working to ensure proportionate learning disability and autism training is developed that meets code of practice, and support, and this one I like as well, support the removal of unnecessary information governance barriers. So, colleagues, there is so much more from this discussion, and this is why I really enjoy and support and commit to making sure that we have an hour each time on important matters and services and support for local communities. So are you supportive of that, in addition of what Rob said, in addition to what we've also discussed today as well? Okay. Thank you so much. Really appreciate that. We will touch on these items again as we go through things like the integrated performance dashboard and considerations going forward for planning. Thank you again, colleagues, Keir, Sarah, Therese, and many others behind the scenes who've helped. So colleagues and our guests and visitors who joined us this morning to share their experiences with Healthwatch and West Yorkshire Voice Forum as well, which goes back to the endorsement of people at the heart of our decision making, which we talked about in the previous items. So more to do, and I'd invite your colleagues to come back, perhaps in 6 months' time. We can talk through with Laura to find out about the progress. There's a challenge on pace and radical change, and there's got to be a way of finding the right timetable and the trajectory of that work as well. So thank you again. We're going to take a 5-minute break now and come back around 3:15, which means our live streaming of this meeting will pause and we'll come back shortly. Thank you, colleagues. Good afternoon and welcome back to the second section of our NHS West Yorkshire Integrated Care Board meeting in public here at the Life Centre in Bradford today. And thank you to colleagues around the table for their contributions so far to the meeting, our guests and visitors who've joined us in person today, and for anyone watching live online or on the recording of this meeting. All our documents are available online to view. It's part of what we wish to do in terms of being open and transparent as an integrated care board and overall in our work in our health and care system. So we're now on item 7, which is my chair report. Board colleagues around the table are aware that I put this together particularly as a record of our governance activities, our partnership activities, and any response that we have particularly to NHS guidance and information. What we have particularly is a note there on our response and work around the NHS England Fit and Proper Persons Test Framework. It's something we've adopted as a board from the start, but we are responding now to specifically the framework that came out in August. You've also got a note there of our visit from Lord Markham from Department of Health and Social Care in July. And thanks to so many people who worked with us that day, these kind of visits don't happen by chance, and nor do they happen in a matter of days. There was a lot of planning there, and I'm really pleased and proud that we managed to showcase the work that Airedale Hospital is working on in receiving money through the new hospitals programme nationally on their RAC issues that they have. We also heard from Bradford District Care, NHS Foundation Trust on their Linfield Mount capital needs, which their Chief Exec Therese Patton talked about a moment ago. Our colleagues from Calderdown Huddersfield Foundation Trust shared their work on Calderdown Royal Infirmary and Huddersfield Royal Infirmary, and Leeds Teaching Hospital particularly showcased their work, again receiving national funding for the new hospitals programme. And I might be sounding like I'm labouring the point, but we have a number of capital priorities within our system, and what you heard there is some are funded nationally and some are not and still seeking funding, and it relates back to a point that we've just had in our mental health discussion, which we may well touch on again later for finances. There's also in that document for the first time highlights of our board level service visits that we've been taking place. There are so many more visits that have taken place than are listed in that report, but hopefully for members of the public and particularly for members of staff, it's Kate's earlier point about workforce are our people as well, about how we're trying to get out and about and be visible, engaged as board members, understanding places, services and the breadth of the NHS and beyond as well. So I hope that's helpful. A couple of things I wanted to just note, just a reminder, and hopefully this is assurance, but it came up in our partnership board meeting back on the 5th of September about queries around maternity, safety and services, that we have maternity safety champions on the executive side, which is Beverly Geary, and on the non-exec side with Becky Mulby. And that is all part of national requirements, but colleagues here go above and beyond that. Bev has already talked today about our work around maternity services, including in our AGM today, and may well touch again on that again later. And also just a confirmation of a change in roles, which I'll report more fully on in November, that Becky Mulby has now taken on chair of the ICB Quality Committee, and Majid is a member of that committee, so we're switching roles there and going forward. So I hope that's a helpful record. It's also for me trying to record good work that Laura and colleagues are doing on the governance side as well. I don't know if anyone has any questions at all. No. I always silence. I'm going to just 30 seconds, Brendan. You were with me on the Lord Markham visit. How did you find it? Because what the feedback from the Department of Health was that's the first time they had been on a system visit rather than just meeting a sole organisation, and they really reflected on our can-do attitude, Rob, which I really welcomed hearing about that day. I don't know, Brendan, how you found that visit.
Very much that. It was a bit of a, come on, everybody needs to crack on. I think he was equally frustrated by some of the overly bureaucratic processes that I think are in place for a reason, but actually slow us down. He did see that there was a can-do attitude here, and that despite being frustrated by some of these delays, we were moving forward with this. I think he liked the breadth of our conversation, and that I think as a system, we had a collective view on what our priorities were and where we should be spending our money and how we could potentially do things differently. But we were asking him to support us in our endeavours and to use us as a test bed for cracking on.
Brendan, thank you. And also very specific on figures on funding as well, which was, it was candid and open, which was what was required. Okay, thank you. So I'm going to move on now to Rob's report, our Chief Exec's report in item 8. So Rob, I don't know what you'd like to highlight with us in your report, and then colleagues, if you have any questions or comments, please just let me know. Rob.
Thanks, Cathy. Welcome the conversation around the report today and some updates that we can provide, given this was circulated a week ago and things continue to develop on a daily basis. So I think it's worth reiterating here, as we did in the annual general meeting, our collective support for being able to speak up. There's been a lot of discussion and debate following the prosecution of Lucy Letby for a number of murders of babies and attempted murders of babies at the Countess of Chester Hospital, and a lot of conjecture around the circumstances in that case. But one thing's clear is that people need to be able to speak up and be taken seriously when they have concerns. And all of the organisations across West Yorkshire have been working with their staff to make sure that they understand that that's part of our culture. And I know that the board is also committed to ensuring we have the right sort of culture and leadership in the system, which is one of the reasons why we continuously talk about the values and behaviours expected of people in the organisation and across the system, that those values and behaviours are tested in senior appointments and the appointments within this organisation, and that they're covered at induction, appraisal and all points in between. Worth also reflecting that there's a lot of debate about regulation of managers, and I've also highlighted the changes to the GMC, suggested changes which would come in from next April to the GMC Good Medical Practice Guidance. Regulation of managers is something that's discussed periodically. There are many people sitting around this table who are regulated. There are many of the chief executives in our system who are regulated because they are clinicians. Brendan, for example, is one of them. Sarah's another. And I think that they go about their business and are able to be chief executives. Mel's another, in ways which regulation doesn't prevent them from having the capacity to get on with it. If managers are going to be regulated, I think that's fine. I think that's fine. We need to do that in service of something, though. And, you know, a common set of standards, professional support, development, culture, all those things are important to consider. So let's see what happens with the government, but the prevailing wind would suggest it's probably going to come at some point. And it'd be useful to learn from those leaders and managers around the table who are regulated, what that means for them in their professional lives. Also worth reflecting that since this was written, this report, there's been a couple of further developments which have been shocking. The first is again, I talked about this in the annual general meeting, but it's worth repeating in the board, is the report into sexual harassment in surgery, which again all of our organisations are following up, and we're doing some collective work through the West Yorkshire Association of Acute Trusts and the medical directors on that issue specifically, and we'll follow up across the board, because if it's happening in surgery, we know it will be happening in other places too. And through the Women's Network, through our leadership, we'll ensure we're going to take the right actions to reduce the likelihood of this happening and hopefully eliminate it. It's also worth reflecting, I think, on probably one of the most shocking things we talked about earlier in the previous session, intersectionality, and the intersectionality of people from minority groups, ethnic minority groups, and learning disability, according to the Race and Health Observatory, is that your life expectancy in England, if you have a learning disability, is 64. If you're from a racial minority group, it's 34. 34. So we need to continue to keep reinforcing the importance of intersectionality and inequalities in every single thing that we do. And the fact that that is one of our statutory requirements and one of the things that we keep highlighting in the year ahead and our strategies is something that I think gives me some confidence that we'll continue to be challenged by these things and also act on them. I mentioned in the report that reinforced autoclaved aerated concrete was something which we'd been involved with for some time. I know that Brendan, in a former role, did give a senior leader in the NHS a piece that had fallen off his hospital as part of one of their visits. And we've been dealing with this for some time, but it's become a national issue again because of what's going on in health and in the wider sector. We've known about it in hospitals for some time. We've been asked for some further assurance. I just wanted to ask Jonathan to give us an update on what we've been doing around other health buildings and the existence of RAC and any assurances that we can give to the board at this point.
Thank you, Rob. So we've been assessing with all of our 10 provider trusts whether there is any presence of RAC in the buildings. We've also been working with NHS Property Services to understand what the position is with regard to primary care estate, particularly around GP practices. The latest information that we've got is that there is no prevalence of RAC in any of the West Yorkshire primary care GP estate. There is a further piece of work that we're doing, supported by some of our advisors, on what's called 3PD, or third-party developer estate, which is a private sector-owned estate who lease premises to GP practices. So there's a piece of follow-up work going on with regard to that. So we think we're in the right place at the moment in terms of at least understanding what the baseline issues are.
Thanks, John. I thought it was important, given the profile of this, that we took that into account. We should also recognise that as schools are affected, our staff are affected because they care for their children who go to schools or don't if they're not open. So we're keeping that closely in view, working with local government colleagues too. Today marks another day of industrial action, and this week we see joint action from consultants and junior doctors and further action in the following weeks. You'll see in the report that I've highlighted that that does have a consequence for us. As I said in the annual general meeting, this is an issue between the British Medical Association and the government. It's their dispute. We cannot solve it here. We do feel the consequences, though, as do our patients and the public. And there's three I've highlighted in the report. The risk of harm for staff and patients increases as we go into the disputes, which now lasted nearly a year. And if people have had multiple postponements, our staff have had to make multiple postponements, that increases the risk of low harm, psychological harm, distress. The second impact is that the more that we do this, the less we have the capacity to tackle the backlog on waiting. And the third is that as we are constantly managing this process in our hospitals, our mental health providers, in general practice, across our systems, we're not focusing on productivity, we're not focusing on recovery, we're not focusing on safety, and well, we are focusing very much on safety. We're not focusing on the things that we really want to be focusing on. So there's a triple impact of the industrial action, which, although it now feels like it's become a bit business as usual in terms of dealing with this, the consequences are felt on our business and the delivery of services and on patients and the public, and we shouldn't lose sight of that. And it would be good if there was some hope of some resolution to the dispute. In terms of other areas, the Integrated Care Partnership, MOU, I would celebrate, and the benefits and opportunities that gives to us. Yesterday, myself and Fatima were at an event led by the Mayor and Dr. John Wright from the Applied Research Collaborative in Yorkshire and Humber, which has brought to us a scientific advisory group brought from all of the resources in our universities and research collaboratives, which will advise the combined authority and ourselves on what's the best evidence possible for the work that we're doing so that we can make evidence-based decisions and that we can evaluate the things that we do to make sure that they make the biggest difference to us. That's one example of the sort of developments that we're bringing. Fatima's roles and the work that we're doing on the economy and jobs, etc., is another. Our work on system of sanctuary continues to be important. Local authority colleagues have been in discussion with the Home Office and their accommodation provider over the increases that we're seeing in people being dispersed to West Yorkshire who are seeking asylum and people who are refugees. And people need to be living somewhere and they need to have safe services. We continue to work to try and ensure those services are safe. The board will be aware of our serious incident report that we had around the dispersal of people to Manston, and we covered that at the last meeting. We continue to have concerns that we're discussing with the Home Office and their accommodation provider around safeguarding and doubling up of people in hotels, which we'll continue to discuss and oversee through the Quality Committee and with our local authority partners. Finally, the operating model work continues. That is driven by several things at once. If we weren't required to make a 30% reduction to our running costs as an organisation, we would still be looking at the operating model, because we have providers coming together to collaborate to deliver services together in different ways. At the session this morning, some of our colleagues and some of the families talked about it'd be better if we had an alliance of people working on mental health in our place, like they do in some other places in West Yorkshire. We also have the delegation of further responsibilities to us as an organisation from NHS England. So we've seen that on pharmacy, optometry and dentistry. What we're now seeing is, from the 1st of April, a suggestion that we pick up responsibility and the accountability for specialised services. And given the changes in NHS England, need to catch up a little bit on this, that the staff are still hosted in NHS England. So we'll need to make a decision around whether we think that that's a good thing to do or not. If board members were to think about it in a way which fits with our previous experience, Anthony and his team very much feel like they work with and for us in the system, but are employed by NHS England. It's the similar sort of approach in that we would be accountable for, the moment we're accountable for performance, improvement, etc., but we're supported by Anthony's team. We would be accountable for specialised commissioning, but the team would sit in NHS England. And we may want to return to the risks around that, given the scale of the resources and the fact that it goes beyond just West Yorkshire later on in the private part of the meeting. I think that's all I want to say, apart from, you know, there's an ask there for people to become champions for our programmes around suicide and suicide prevention. So if people do want to do that, then please get in touch. Thank you.
Thank you very much, Rob. I was going to reiterate that in an invitation to board members to become suicide prevention champions, and you've already provided the web link to start the online training, which is really helpful. Thank you. I also want to thank many colleagues around this table and elsewhere, including Tim and Kate and yourself and many others who are working on the nationally required 30% reduction for all integrated care boards, all 42 in this country, including us. And I know there's been a huge amount of work that has taken place alongside the day job as well, which is very much appreciated. Does anyone have any questions for Rob in relation to his report today? No? Bev?
It's not a question. Excuse me, it's not a question. I just want to point board members to the point 5 of your report, or 50, on 100 children and young people's Project Hope. So we, the West Yorkshire ICB, were successful in becoming one of 10 ICB pathfinders to support young people leaving care. And this is a really good initiative for people that have been in care for most of their lives. I would ask members of the board, and we'll go back to your organisations if you're not within, within the ICB and others, and people that may be streaming live, to consider becoming a pathfinder. So what that means is you offer a placement for 6 to 12 months for school leavers, for care leavers aged between 6 and 25 within West Yorkshire to access career opportunities, and particularly in health and social care sector, and to harness the young talent. So I just wanted to point that out, Chair, because we've got quite a lot of people that we're trying to engage on this really brilliant project, and to support them in West Yorkshire would be a really good thing for us and for them. Thank you.
Thank you. And for those of you that maybe didn't attend our partnership board meeting on the 5th of September, we heard from someone with lived experience who was also part of that project as well, which was really powerful, and also from a number of local authority colleagues who've been having positive experiences in offering these placements. Harris, did you want to respond on that? Oh, okay. Let's go to James, and then we'll come over to you, Harris, and then Robin.
Again, it's not a question, but it's picking up from the paper in terms of asking for an update on the vaccination. It's just really just to highlight to board and to others that the autumn campaign has commenced for both flu and COVID vaccination. Due to concern for the kind of new variant that's highlighted in the paper, the BA 2.86 variant, we're asked to bring this forward and do it faster. So I just want to thank our primary care networks, our community pharmacists, our trusts and community teams across West Yorkshire for kind of stepping up to do that. Because, so from last week, the care homes were started, and we started going out to our care homes there. And then from this Monday, it's been wider there for those who are eligible to that. And it is about learning from kind of previous year, or the previous campaigns there, learning and to ensure that kind of we get the vaccines out to those who are eligible and can take that up there as well. So the aim is to finish by the 22nd of October for care homes, and the end of October for, generally, but it will carry on after that there. So I just wanted to highlight as requested in the paper.
Great, thank you very much. And as health and care leaders, I encourage you to promote that far and wide. Thank you. Harris, you said you have a question.
Just on the industrial action, healthcare students are still required to make up their mandatory placement hours, and just seek an assurance that there's support available for them within the NHS trusts and universities, that they won't be asked to do stuff that's beyond their ability.
I don't know, James, if you want to comment on the professional elements of that particularly.
Yeah, no, Harris, I mean, I think one would not expect anyone to do any sort of procedure or care that wasn't within their kind of professional ability there, basically as an undergraduate there. The same as anyone who was postgraduate as well there. So I think it's the same. One would expect that from organisations. I would know that would not happen across West Yorkshire. Speaking with the medical directors, I don't think there's any expectation of that. I think it is about how we support our organisations during this time there. But it's not about going above and beyond in terms of your professional duties or what are the expectations there.
Great, thank you. And Harris, another reminder, thank you, of our university population and also the importance of placements. Robin.
Yeah, thank you, Chair. I just want to build on Rob's comments about migration and asylum, just to say that there is an additional range of challenges that I think will test us on our system of sanctuary, but I think we will be determined to stick to it. But there is the doubling up in hotels and the need for proper health checks and assessments there. There is not just the increase in dispersal, but the increase in decision-making linked to trying to reduce the backlog with sometimes only 5 to 7 days' notice, and the risks for all local authority, voluntary sector, NHS colleagues around homelessness presentation, around people moving out of accommodation, dispersed accommodation very rapidly, and that's likely to accelerate. There's an increasing issue that we are working with the Home Office and the supplier on around age assessment and the identification of individuals that have been assessed as adults but are actually children. and the implications for that, both in terms of that individual being in and their well-being, being in a hotel primarily, but also the duties of the local authority to then have them as a looked after child and leaving care responsibilities, and that's an issue. And then the final thing is, you may have seen the recent judgment against the Home Office and Kent County Council around the number of children and young people seeking asylum who are particularly in Kent, and the now escalating relocation of those children and young people to all parts of the country, and that will include West Yorkshire. So we expect an increased number of children and young people with the support needs that they will have. So just to highlight, unfortunately, this will be more challenging than ever, I think, going forwards. Thank you.
Thank you, Robin. There was mention of taking that to Quality Committee for oversight, which I know was done before. Are there any requests today, particularly for people working in services or place committees? It feels to me this is a watching brief going into winter as well. Is there any specific request of colleagues around the table?
I think, no, take it there, and I think we'll be picking it up in all our place committees. Thank you.
Rob.
Yeah, the board should be assured, and looking round at the faces of colleagues who work in place, that the operational reality of dealing with very rapid arrival of people into our, places, many of whom will have faced trauma, some of whom will have faced torture, some of whom will have had incredibly difficult journeys to get here, is a matter that they're dealing with in their places, collectively, and with the right approach. What we're trying to do is to make sure that we have as much notice as possible, and that the arrangements reflect any information that's available about those people as they arrive with us. That hasn't always been the case, so we've had to intervene and make rapid assessments and put things in place to keep people safe and well. So I think that operational reality feels to me that something people are pretty good at. I think what, as Robin says, we need to do is to make sure that we're being more planful about the likelihood that there'll be more people arriving who need more support and help, and what that actually means for us. I know we've been talking to colleagues regionally and nationally as well about what that might mean for how resources flow subsequently.
Okay, thank you. We'll have it as a watching brief, and thank you, Robin and Rob. I know even you've had conversations even over this weekend. This is how passionate you are and committed you are to making sure that we do this right in our system. We've made a commitment to be a system of sanctuary. And Robin, we've talked before about whether you want to come to partnership board and that more broader discussion about being a system of sanctuary, and we could revisit that in future. I know our colleagues in local authorities also continue to work on safeguarding under their statutory duty, as well as we do in the NHS, and perhaps that's a point of exploration into winter and into the new year as well. Okay, thank you very much for raising that. So colleagues, we've got around 40 minutes left and still a lot to do. I'm grateful to you for your time today. It's always the nature when we've got a big agenda, and today we've also brought in our annual general meeting. We've now got items on system performance, our integrated performance dashboard and corporate risk register, including our financial performance with Anthony, Jonathan and Laura, winter planning update from Anthony, for the record and any immediate queries, our committee AAA reports, which gives you a snapshot of what's been going on in parts of our governance, and then some approvals around terms of reference. So let's see how we do together in trying to land all that by 4:30 or so. Okay. Anthony, Jonathan, and then Laura, are there any highlights you want to make for those reports? And thank you again for continuing to take on board our feedback, Anthony, to make sure that this document is useful to us all.
Yeah, thanks, Chair. And I am conscious of the time, but I'll just make some brief introductory comments on the Integrated Performance Report. And if I can just thank Becky Malby as well for providing some comments and questions in advance, which I'll touch on briefly, if that's okay. So just to note that we're continuing to develop the report. This builds on the new format that we agreed at the last meeting of the board in July. Colleagues might recall that we set out a plan that in alternate months we'd have a report on the a detailed report on benchmarking, how we compare with other systems, and that was in the July report. And we'd alternate that with a report on progress against the 10 big ambitions which underpin our strategy. So this report includes that update on the 10 big ambitions. Just to clock, there's a slight mix-up of slides in the narrative on that. I think that the narrative on ambition 2 is in amongst the ambition 1 slides. So just to note that as you're trying to make sense of the narrative. Just to sort of navigate you in terms of what data we're looking at, the report contains the most up-to-date available published information, and that means it actually refers to different periods depending on the publication cycle for each metric. Most of them are around the sort of June-July period. Some of them are somewhat older than that. So the IAP data, for example, just looks at the period back to January, which clearly isn't very helpful. We do think some of these ones, in particular the IAPT one, there should be more up-to-date information available. So we are discussing that with the data provider at the moment, and we'll look to get to make sure that the most up-to-date information is available in future reports. So I think that's the sort of main points to note in terms of the format and the progress of the report itself. I'll just pick out a couple of headlines in terms of things I wanted to draw to the board's attention on the data itself, starting with urgent and emergency care. And I think I just wanted to flag that there's a generally positive picture around reducing long waits in A&E. The 12-hour A&E rates are showing a reduction. And we actually have some further positive developments in the UEC system. So Brendan has a shiny new A&E department at Huddersfield Royal Infirmary, which is due to open in the coming days and will have a significant impact on the experience of patients using that department. I visited it myself yesterday. I was really impressed by just how great an improvement that's going to offer for local patients. We also have secured funding for a new urgent treatment centre at Airedale Hospital. So there are a number of developments there which are going to, I think, really help us continue to make improvements in UEC performance. On cancer, I just wanted to note that we've got a generally positive picture of performance in comparison with other parts of the country. That's not to say we're actually hitting all of the standards, we're not, but in terms of the progress we're making to recover the backlogs caused by the pandemic, I think providers of cancer services in West Yorkshire are doing relatively well. Nationally, there's been an agreement to actually change the standards which monitor cancer, access to cancer services. The 10 standards will be reducing to 3 from October, with a particular focus on the faster diagnosis standard and the 31 and 62-day referral or diagnosis to treatment standards. So just to note, that will be a change in the detail of the reports in future. I should say the Cancer Alliance is very clear that they'll continue to monitor, shadow monitor, if you like, all of the existing standards as contributors to the ones that will be nationally the sort of the point of focus in future. Moving on to elective care, just wanted to note that we're making progress to reduce long waits. So 78 weeks waits should have been eliminated by March this year. You'll see in the report that we still had 75 in June, and we have made some further progress on that in recent months, looking at management data. But I do want to flag that progress with that is being impacted by industrial action, as Rob suggested in his Chief Executive's report. So while we had expected or hoped to have eliminated 78-week waits by this month, I think it is going to take a few weeks longer and is still subject to the further impact of industrial action. And I suppose just given the context of today's meeting and the focus on mental health, just wanted to just draw colleagues' attention to the indicators on IAPT's waiting times and early intervention, which are all positive. I think we're ahead of the national standards or benchmarks on those services. We are looking at what further information we can include on children and young people's mental health services in this, and that's been slightly limited by what's publicly available. But again, by the next report, we're aiming to include a bit more detail on children and young people. So I could go on, Cathy, but I'll stop there given the time and ask if there's any questions on that.
That's great. I'm going to, I'll note questions. So, Becky, I've just seen your hand go up, and then Harris, and then Mel. But I do want to invite Jonathan and Laura just to give us an overview, and then we can take those set of documents as a bundle. Jonathan, over to you.
Thanks, Chair. So, in terms of the financial position, we continue to have a very challenged financial position this year across the system, both in the ICB and across a range of providers, primarily the acute hospital service providers. So the data we've got in the pack relates to the position as at month 4, so as at the end of July. And I'll do this in sort of 4 separate parts. So the first is what's the year-to-date position? So as a system, we had a year-to-date actual deficit of £36 million. That compares to a plan of £9 million deficit. So as such, we are £27 million worse than our plan at month 4. So that's the first thing. That variance from plan is primarily in the ICB and 2 of the acute. Sorry, yes, of course, I'll move this. Is that better? Okay. So the £27 million adverse variance to plan is in the ICB and in 2 of the acute hospital providers. So that's the year-to-date position. Just to recap on our plan, so as an ICB, we agreed a £25 million surplus plan. That was offset by a combined plan deficit in our NHS providers of 25 million. So as a system, we had a balanced plan, and that was what we signed off at the start of the year. In terms of a forecast, since the start of the year, we've been reporting a break-even position on the ICB, which is £25 million less than plan. And that relates to the system risk or that improvement in plan that we signed up to as a board at the start of the planning or at the tail end of the planning process. Providers are all still forecasting delivery of their plans. What that means is as a system, we are forecasting a £25 million deficit and have been doing for the last few months. Supporting that, we continue to look very closely and rigorously through the Finance Forum at what the risks and opportunities are that every organisation is facing. And we continue to report that through our system executive meetings and also through the Finance Committee. The current most likely assessment of risks and opportunities suggests that we are holding up to £90 million worth of net risk against plan at the moment. And the paper in the pack describes a little bit further about where those areas are. In short, though, they are around, and some of these issues we've already talked about through a different context today, they are around the impact of industrial action in terms of the direct costs of providing cover. It also relates to the loss of income related to the loss of activity, again related to industrial action. We have experienced instances whereby the levels of inflation that we're seeing in our provider cost base and indeed in the IC cost base is greater than planned and nationally assumed levels at the start of the year. We are continuing to see both price and activity pressures in the independent sector, in continuing healthcare and also in primary care prescribing. And we also have some slippage on efficiency on our efficiency schemes. Those issues, to a certain extent, are prevalent and common across most ICSs across the country. We are continuing to explore mitigations. Those mitigations, that exploration is now supported through a system transformation and efficiency group that we spoke about probably 3 or 4 months ago now. So that's a group that's been set up that's jointly chaired by Carol and James, bringing together a multidisciplinary team. And we continue to review the position both through the organisations, through places, through the Finance Forum, through the System Oversight and Assurance Group and through the Finance Committee. So that's the position that we're at on revenue. Just to conclude it, we do continue to both achieve on a year-to-date basis and a forecast basis our mental health investment standard obligations. Our agency spend is within plan and within the NHS England cap. Our capital position is in line broadly with plan, although there is an emerging risk around how NHS England distribute funding for leases that are now have got to be capitalised this year, which is an in-year issue. So we need to understand that in a little bit more detail, which we will do in the next few weeks, we hope. And the final thing, which again was referred to, we continue to develop the work on the medium-term financial model. That will be going to the System Oversight and Insurance meeting in September, the Finance, Investment and Performance Committee in October, and back to board in November.
Thank you, Jonathan. I'd always welcome how you, in an accessible way, explain system finances for a £5 billion budget on how we bring so many people together to work on this. So I appreciate that. We'll have some questions now, but in the private setting later, we'll also get into more detail on that because of the nature of the finances, and it is a work in progress moving feast. Laura, over to you on the corporate risk register. What would you like to highlight? And just before you start, I've got Becky, Harris, Mel and Majid. Anybody else want to comment on item 9? So I've got a no. Okay. All right. Laura, to you.
Thank you. I'll just run through a few highlights. So this report marks the end of the current risk cycle. As always, it's made up of a number of component parts. Firstly, the main corporate risk register, and then we also have risks that are sitting on our place risk registers that are either high level because they have a score of 15 plus, or are common across one or more of our places. There are 44 risks for review for you today on the corporate risk register, which includes 3 that are new risks. They are set out in detail within the report, but just to highlight, they relate to the acute stroke pathway in Leeds, the national trajectory to reduce the stillbirth and neonatal death rates, and primary care complaint services. So those are the 3 high-level ones for you. Every risk that is on the risk register has been reviewed by either the Finance, Investment and Performance Committee or the Quality Committee, and you will see within the report there is a summary of some of the discussions that took place at those committees, both to give you assurance that they are being fully reviewed as they work their way through, and also to highlight those that were felt to be most important when we were discussing them at the committees. I think the only other thing I just was wanting to highlight today was just, you will remember me saying at the last meeting that we were going to have more of a deep dive into those risks that have a likelihood score of 5. The definition of that is a risk is almost certain and is expected to occur, and we felt that as a number of those had been at a 5 for nearly 12 months, that actually we may well need to move them to being issues and look at the risks that result from that. So that work has been carried out throughout this risk cycle and is continuing. I think you will start to see some of the impact from that this time, and that will continue as we move forward. And we are also planning during the next risk cycle to start to think about how we can develop issues logs in order to try and support the risk register to be focused on potential risks rather than things that have already happened. Other than that, those are the only things I was going to highlight. The details in the report, and obviously the benefit comes from the discussion. Thank you.
Thank you very much, Laura. And for anyone with us in the room today or watching on live stream, a risk register is really helpful for us to understand through committee work. It's making sure that we've got oversight on it. You've heard words today about we're seeking assurance on this. We want to be assured that there's mitigations in place. Colleagues are talking in a very logical way, but it doesn't mean that we don't care. But this is sometimes talking through the metrics and high risks enables us then to have deeper discussions within services and places. So, Becky, you are first on the list to ask a question. Over to you.
Thank you. So let me just bring this a bit closer because it's quite harder to hear. I understand that. All right, so some issues are just around patterns and trends. So if you look at, for instance, and I'm mindful of our question from the public earlier on today as well, if you look at our ambulance wait times, our category 1s and 2s, you know, the benchmark was moved to 30 minutes from 18 minutes. So when we're looking at like for like, it's quite hard to do that over time. So I don't know whether we still collect the 18-minute data, but if we do, I think I'd like to see it so that we can see over years what difference it's making. Otherwise, you just move the goalposts. And we, you know, when we want to in Quality Committee ask about harm, which we do about these issues, I'd really like to be able to see the patterns. So if I look at the ambulance response times, I see where we are in July is sort of where we were last July, and then I look at where we ended up in winter last year. So it'd be really helpful, I think, at some point to have a conversation. Maybe we can have this when we're talking about preparedness for winter, about whether this is just the pattern, in which case we're going to hit those reds again next winter or not. Or is this... So when we're looking at our dashboard, I think patterns and trends are really helpful. I think it'd be helpful, Anne, if we could draw some of those out overall. So are there any concerns when we look at those individually versus where we look at those in place? So have we got any places that are sort of flagging up across, as well as, at the moment, I'm having to delve into every single one of them to have a look for it. So that was the first thing. The second thing is when we're looking at things like when we look at our ambitions, when I look at the patterns and trends on our ambitions, all the things that we have authority over or control over, so things like early diagnosis of cancer, we're making good progress. All the things that relate to poverty and austerity, we aren't. So what does that mean for our ambitions? What's the point of setting targets if we can't meet them because we have policy nationally that undermines those targets? They're outside our ability to handle? Or is it that have we got to get real about those? Are there other things we can do about them? So I think we've got two things in the ambitions. There's those things, the ambitions that are absolutely within our control, and those things that aren't. One of the ones that is in our control, primary care, is around people with learning disability having health checks, and we've still got 3 places that are below 50%. That really worries me. It's a really strong indicator for me about health inequalities and how we're treating people fairly. So I want some response to that, please. And the last one was just on the ambitions. It's just the carbon influencing net metrics look a bit rubbish, to be honest. They don't really look like the things that I would think count around. If we're going to be a leader in climate action, those don't strike me as leader in climate action metrics. So I would like, could we go back and have a look at those? And lastly, Jonathan, thank you for the finance report. You know what I'm going to say, which is it's always good to have in the public domain those issues that are absolutely within ours around our own productivity, and those issues where we think the decisions are out with this system. I'm not saying we don't take responsibility for them, but if we have significant impact of unresolved pay disputes, I hate to say industrial action, it sounds like we're blaming the wrong people here, but unresolved pay disputes that have a huge financial impact for us, I still like to see that reported separately from the things that we have absolute direct control over, where we knew those things were coming and we're working hard to resolve them. So we reported those last time, and I think if we could continue to do that, that would be really helpful. Thank you.
Becky, thank you. I'm just going to go over to Harris. So we've got a point on Yorkshire Ambulance Service, ambulance handover times, previous targets and new ones, poverty affecting the delivery of targets. I don't know if, Ian, you could come back on that. LD assessments, learning disability assessments by place, carbon influencing targets. I think this is one for our colleague Frank Swinton to work with us on and develop further. And factors known and unknown when we set the budget and in and out of our control. So I think that's just a very helpful reminder. Harris, we'll come to you and then we'll ask colleagues to respond. Do you want to borrow Mel's? Won't turn off. I'm sorry, my mic won't turn off. This one's working.
Oh, they're on now. Just a point on ambition number 7, linked to ambition number 7.
Okay, I'm using a different mic. Bev, could you come back to us on that, please? Do you want a couple of minutes, or can you do that now for us as system maternity safety champion, as well as perhaps referring back to the work that you talked about earlier, as well as what we're doing with systems and providers? Thank you.
Absolutely, thanks. So I'm going to talk a little bit more about the maternity transformation programme, and then I'm going to come to specifically to Leeds, because West Yorkshire, we are an outlier in terms of neonatal deaths, and that's for a number of reasons. So there's a national maternity transformation programme that was set out to achieve the vision in Better Birth. So it dates back to 2016. So it's a really well-established improvement programme that has local, regional and national scrutiny. So that's the first thing. So in terms of the LNMS, and linking back to the new risk on the risk register that I was going to come back to actually, is we've got a risk that we fail to achieve the ambition set out in Better Birth around halving the neonatal stillbirth rate, or the neonatal death rate. So we were on track before COVID. And then, like the rest of the country, there was a significant impact, and we saw a rise in stillbirths. We really focus in terms of the LNMS. We've got a focused piece of work, but given some of the complexities within our system and some of the choices that I will talk a little bit about in a moment, we're still an outlier. What I would like to reinforce to the board, though, is these are really small numbers. These are single figures, but clearly each one baby death is far too many. So in terms of Leeds, Harris, Leeds is a tertiary centre. We get the sickest babies there. We get babies from not just across Leeds and across West Yorkshire, but out of region and sometimes, various parts of the country. So they're really high acuity and high mortality. But what I would like to reinforce is that every intrauterine death and stillbirth is investigated under the Serious Incident Framework or by a national body. This is reported in detail at each organisation to their board via their quality committees, and it's also subject to system, regional and national scrutiny, so every single death is reported. So, and the complexity that we have in our system, which is different to some other systems, or quite a few of other systems, is about choice. So as a result of cultural and religious reasons, some pregnancies that we know won't result in a live birth continue as a result of women's choice. So often we know this is going to happen, but we still investigate as we would any other neonatal death. I hope that answers your question.
Thank you, Bev. And I know this is something that you continually to look at. We're going to have that through Quality Committee again. It's a watching brief for us, particularly because of the risk and the statistics. And I'd just say for anyone in the room and for anyone watching online, if you're affected by that, because Bev has tried to explain that, and some of it is NHS speak, but it links with the reporting and the requirements that we have. We'll make sure that there's information available online on seeking support with that. Can we come back to the points from Becky? I don't know if, Rob, you want to respond. And Ian, can we come to you first? Thank you.
Yeah, thanks, Cathy, and thanks. I think they're both really good points. On the point around poverty and inequalities in the strategy, we included those in the strategy because that's what people in the engagement said was really important to them, pretty much all partners. I absolutely recognise that we are one contributor to that amongst a number of other partners, and that's why we put some of those sub-metrics in, like CVD prevention, COPD prevention, and so on. I still think we should have metrics around inequalities in there, but just be clear that actually it's a multi-agency response, and a lot of it relies on sort of national policy as well as local policy. So I think just being a bit clear about that might be helpful. On climate, Becky, you're right. There's a lot more going on than we've written in that slide there, so we can do a better job on that next time round.
Okay. And just to note, at our partnership board on the 5th of September, Ian, you brought a look forward plan. So for everyone around this table and for members of the public, they can see each topic we're going to be looking at every quarter with colleagues across council, voluntary community and social enterprise sector and the NHS. So we can then have that full sight. And I think that's a point, Becky, where we can then bring in some of these developing metrics. Kim, did you want to come on that point? Okay. Rob.
Yeah, so just to remind everybody that when we decided on the strategy and the board assurance framework, one of the big strategic risks is exactly the one that Becky described, which is the external factors are so great that we can't deliver what we want to around making improvements to people's life expectancy. So we do need to keep coming back to that. Now, one of the things that the board should keep in view is that the major conditions strategy is about to emerge. There's been a strategic framework published for that. The evidence for that shows what are the big drivers for early mortality. And they come down to behavioural, the way they describe them, behavioural, clinical, environmental. So the behavioural ones are the ones you'd expect, so smoking, alcohol, obesity. The clinical ones start with hypertension. And you'll remember at the last partnership board, I said to everyone should know your numbers because hypertension is something which causes early death. So we can do something about hypertension, and we can do something about diabetes and HB1AC, etc. And then the third group are about the cold, your occupation, and air quality. And our partners can do something about those things. But that middle group, what we might want to do as a strategic choice in the future is to say, given the context we're in, we might focus on the middle group. But that will be something we need to feed into our business plan for next year.
Okay, thank you. Becky, very quickly.
Just the LD health checks.
The LD health checks, I'd ask place leads to take that in. Yeah, and I think for you as new quality committee chair, I think there's oversight on that as well, of course. The other points you've made, I think, are just very helpful to absorb in and develop our reporting. I just want to get through the last few. We're aiming to try and finish in the next 10, 15 minutes or so, and we still have winter planning to do. So can we go Mel, Majid, Fatima and Kim? And if you, I'm sorry to ask you to make brief comments, but if you would. So Mel first.
Thank you, Chair. I just wanted to give the board assurance because on page 198 I can see that we haven't captured turning points IAP recovery figures. So I just wanted to share with the board that we were achieving 53.6% at the last reporting period, and I just wondered if there's a way we could capture turning point in this report moving forward in terms of their activity. I don't know if this is something other places are seeing, but interestingly, although we're meeting our national access targets for talking therapies, we have seen quite a drop in referrals in Q1. So we've just done a concerted effort with our PCNs to really push mental health support by talking therapies, and that has had an impact in the last 4 weeks in terms of number of referrals. I'm not sure at the moment whether that's just, you know, a Wakefield issue or whether that's something we just need to keep an eye on as a West Yorkshire.
Okay, if we can take that as an action, Mel, but I think this is helpful. And Anthony, again, grateful for your patience as we finesse this in terms of measuring to make sure that we get these things right. Majid, then Fatima, then Kim.
Okay, 2 quick points. First one, just building on the inequalities point. Oh, is it? Okay, sorry. 2 quick points. First one, building on the inequalities point, the data. Demographic data, whatever we can, we should start bringing it in, otherwise we won't really get a feel of the difference we're making on reducing variations and inequalities. So, and then the second point is on ambition 8, diverse leadership. Really good to see the fellowship program up by 200%, but we're still not where we need to be. I know we introduced this inclusive recruitment toolkit. It'd be good to get a feel of how that is working across the region.
Thank you, Majid. And I know we're also asking that through our partnership board as well, but I think we need examples of that. And I know, Kate, you'll be involved in that as well. So let's make sure that we programme that in going forward. Okay. And demographic, another point there on making sure we're bringing forward relevant demographics for reporting linked to variations in access, or good and bad, we need to understand. Okay, Fatima and then Kim.
So I'll be really brief. I mean, it's in response to Jonathan's really comprehensive financial briefing. And I don't think you can emphasise enough, Jonathan, just how challenging the financial situation is despite the best efforts of everyone around the table. I wonder, just being mindful of several media reports regarding investment and the sustainability of the NHS, whether we're being clear enough in our communications to the wider public about just how challenging the situation is. We've seen some of the benefits of community influencers or people amplifying some key messages about where this money is going and actually the impact it's making. And I wonder whether we could strengthen that to ensure that the public are fully aware that despite the financial situation, we're providing a really good service to our public.
Jonathan, I'll give you a moment just to prepare a response, and Kim, to you.
I just wanted to flag up on the risk register that you'll note 2120 that the risk of loss of ECSE services has gone down on the register. That is as a result of conversations about recalibrating the risks in relation to some of the other risks that are on there, not because we really think that the risk has gone down. In fact, in some cases we've discussed that it has increased and crystallised as more of an issue. So we're picking that up, we're having conversations, so I'm going to be bringing back a report on that. So I just wanted to flag that up. That's the reason why it's gone down.
Thank you, Kim. That's really helpful clarification. And then we can, as we're inviting Ian to come back looking at primary care, you gave us such a great report and the sessions that we had back in March. So invite you to come back again as well so we can track the story and also help and support you on sustainable commissioning for the medium to long term for the sector, which I know we're very committed to trying to achieve. Okay. Jonathan, are there any points there just particularly on what Fatima shared, and then we'll move on to winter planning?
Yeah, thanks Fatima. And in some ways it's similar but slightly different from the conversation that we were having with Kim at the last board meeting around can we get some clear messaging out to some of our partner organisations, particularly in the VCSC sector, around what it's feeling like financially wise in the NHS at the moment, and probably local authorities as well. And we said we'd do that after this meeting, because we're probably starting to produce more information in that regard for today. So I think we might be able to do something. I think we just need to be mindful not to be seen to be lobbying for increases in funding within the mandate that we've got. I think we just need to sort of strike a bit of a balance on that.
Okay. Thank you. Again, continuing to be open and honest. Mel?
I'm just really anxious for some of our voluntary sector organisations that are really struggling to meet the cost of living, staffing cost impact, and some of the challenges some of our organisations are making in having to go into, deficit conversations when, they rightly so want to pay their staff maybe a 5% increase, but we're not uplifting contracts at that level. So I just feel like that's a conversation we need to have outside. Perhaps me and Kim and other colleagues who are interested could pick that up. Sorry, that's not appropriate to say that. But.
Thank you, Mel. And I think we've collected a list along the way today of things that we want to ask place leads and place committees to look at with their independent place committee chairs, as well as points that will come through in ICB committees. And then we'll make sure that comes back as a thematic update on where we are. But let's not wait for 6 months for a meeting. Let's have those discussions this week, this month. Okay. Thank you. I'm going to move us on now to winter planning. Anthony, thank you so much for this update. I find it really helpful, including that mapping of who's doing what, when, which is really great. And also for anyone who has been tracking our work, we do have a document and report out in the public domain from our March meeting this year on our learning from 22-23 winter, and this is for 23-24. So what would you like to highlight with the board? And if you've got a question, please let me know.
Thanks, Chair. So colleagues have mentioned a number of times already today just how difficult last winter was, and clearly that demonstrates how important it is that we plan as carefully as possible to address the challenges we know will be repeated this winter. So that the purpose of this paper is just to give assurance to the board on the approach that we're taking across the whole system to plan for winter. It covers work across 4 broad areas. The first one is around, if you like, a self-assessment in places and organisations against a set of high-impact actions that nationally we've been encouraged to look at, so that the paper sets out how the priorities have emerged from that work. The second area is around work on surge planning and looking at the additional capacity that we'll need in our hospitals and community services and care services in the winter. And just to note that the first iteration of our revised capacity plans have just been submitted to NHS England's regional team last week, and that'll iterate over the next couple of weeks in terms of further discussion with regional colleagues. The third area that the paper flags up is the work that we're doing to make sure that we're working as effectively as possible collectively across the system, and some of the arrangements we're putting in place to support the really good partnership working that we already have across places and our provider collaboratives. And then finally, there's a section on what we're doing to support the workforce in terms of recognising the pressures they'll be dealing with throughout the winter, and how we'll be supporting them, not least, of course, in ensuring people have the opportunity to be vaccinated against flu and COVID. So I'll just stop there, Cathy, in terms of those being the headlines of the paper, but if there's time for any questions, happy to take any.
Great, thank you. And Anthony, as we did last year, in our first year, that we'll have this as an agenda item as we go through winter, and then aim in March to have a reflection and learning, as well as we can talk about it in July next year as well. Because actually, Bev, you shared with us back in March that there was learning from winter that helped us with things like bank holidays and Easter, for example. So this is a point of continuous learning. We've got comments and questions from Harris, Rachel and Richard. So Harris, you first.
Just on the prevention point, I was recently reading the Kirklees Director of Public Health report, on poverty, and it stated how few people are taking up their NHS prescriptions and buying over-counter medication, and the rising number of people unable to travel to access healthcare or other support. This is only going to get worse in the winter, which will result in additional pressure on the NHS if they can't get the medication or get to appointments. So I'm keen to hear from public health colleagues about what other things we can do to ease pressure on the system.
Great, and not planned at all, but we'll now come to our public health colleagues. So would you respond on that first, and then we'll hear your query question?
Yes, thank you so much, and obviously thank you to Harris for reading the report. I think it probably links a little bit back to what Becky was saying about there's national policy and there's how we can or can't influence that, but then there's almost how we are understanding the impact of poverty and the cost of living crisis on how we're delivering our services. And I think what struck us about the report was the fact that people were, you know, not reordering their repeat prescriptions as regularly as they could do in order to save money. And obviously some of those things are quite invisible in terms of how we're delivering our services. So I think I've sent Jonathan some stuff that we've tried to do around an integrated impact assessment that looks at poverty as much as you look at things like equality and other protected characteristics. It's not going to solve everything, but I think that there's how we have a mind to that when we do things. And I think that certainly in the Improving Population Health programme, we've talked about how we take services to people at the times that work for them, because if people are going to be working, you know, multiple shifts, complex jobs, multiple jobs, there's definitely something about, it's not just making sure a service is in place, it's making sure that people can get access to it at the right times. Because I just think that mitigates some of those cost of living and poverty impacts that might help and be the difference between a successful winter and perhaps not a successful winter.
Okay, thank you. Karen, do you want to follow up on that, please, very briefly?
Yeah, please. Just to say it's important that we make sure that all our colleagues understand that. If I think about some of colleagues in community who go into people's homes, often they are bringing blankets, and we've provided some. I know my colleagues in Leeds have done the same, but actually giving people the money to get on the bus to go to their appointment. Yeah. So to make sure that we all know would be really powerful, because we need to support our colleagues in that space as well as our communities. Thank you.
Okay, so we take that as an action, but that is something, again, that's going to happen this week, this month, and then we can hear an update on that back in November. And then seamlessly we come to you, Richard. I don't know if you want to respond on prescriptions and GPs as well as share your point.
I think I just wanted to remind the board, sort of, you know, as Rob has done and Anthony has done already, that last year was one of the worst years that any healthcare professional has experienced, and we don't want to repeat that again. And so I am concerned that there is a lack or no investment in primary care services as part of the government plans and the ability for us to invest. Indeed, in Leeds, the same-day response service is being stopped rather than actually being expanded or increased. So I think we have real concerns about the lack of capacity to respond if there is a repeat of what happened last year. And whilst my general practitioner and pharmacy colleagues are busily vaccinating as many people as will come forward, and I encourage everybody to come forward who is eligible for vaccination for COVID and flu vaccines. Nevertheless, we are very worried about sort of the impact of the lack of investment in an already overstretched service.
Okay, thank you. I don't know, can Jonathan, I don't know, you or Rob would like to respond, or Anthony? Anthony?
Yeah, thanks, Chair, and thanks, Richard. The approach to investment to prepare for winter has been different this year in the sense that it was all front-loaded in allocations rather than given as an allocation at this point in the year, which is what we've been used to. So I think that means there isn't any visible new investment, if you like, specifically for winter for primary care. I think we're going to have to look at this collectively across places and across the system in terms of the risk that creates and what that means in terms of where we might need to focus disproportionate effort to support primary care. So we'll take that away as something to look at as part of the next stage of the planning.
Thank you. Ian, did you want to come in as well on primary care?
Yeah, I completely agree with the points that Richard just made. We are hopeful that there may be additional funding for acute respiratory infection hubs for primary care, as there was last year. Still conversations going on about that, but we think that may be additional to the 200 million that's been identified.
Okay, thank you. Colleagues, are we happy to support this plan and to continue having this as an agenda item going forward. And actually in between then, there is so much work that will go on week to week, and I think a recognition of chief operating officers working in the system, which are key people who help to make this happen. And we'll hear more as well about the role of the ambulance service, as well as working with our variety of provider collaboratives, including community and our acute colleagues. Okay, thank you, Anthony. That's really helpful. I know we've got to meet an NHS England requirement, but I'm really pleased that we had conversations about issues around poverty and bringing in our public health colleagues as well. Okay, thank you. Something that I just need to do in going back in item 9, we have a dashboard. Anthony just gave an overview of how the dashboard's working going forward. I think if you've got any feedback or any particular metrics, please let him know, but we're happy to receive this format. So some meetings we're going to see the overview as a system. Sometimes we're going to see ourselves benchmarked against other systems. Are we happy to take that going forward? I can see nods around the table. Thank you. Okay, we then have our committee AAA reports. They've been referenced throughout. There was a point earlier that was made around learning disability assessments, for example. We note, particularly across place committees, you're all looking at financial pressures and challenges, as well as other elements. And I can see deep dives going on, as well as continued commitment to listening to local citizens and communities, which for me goes all the way back to item 5 today about making sure we've got people at the heart of decision making. I'd encourage colleagues to, particularly say, for example, on Quality and Finance Committee, to talk to those place leads and gain that information. Is there anything pressing from those reports, or can we take those as read? I'm going to take those as read. Okay, and I think there's oversight AC in terms of the ICB Finance Performance and Investment Committee about having that oversight by place, as well as, of course, by sector as well. Okay. Thank you. We then move on to a governance item. Laura's just going to give us a quick update, but you're being asked to approve these documents, board colleagues. Laura.
Thank you. Yes, so part A of this report is asking for approval today to make some amendments to 2 of the ICB board's committees. The first one is the Transformation Committee. I would say that the committee is continuing to evolve how it's working, so this is very much an interim request to amend, and I think you will see them again with some further amends, possibly at the next meeting. And the second one is a request from the Bradford Districts and Craven ICB Place Committee, who are seeking to amend their membership, so seeking approval for that, please.
Okay, colleagues, are we happy to approve those documents as they are today? And I know with the Transformation Committee there's continued work. That's transformation for you, isn't it? So you're continuing to come together on the development of that. Okay, thank you. Also, good governance as usual. Is there anything else, Laura?
Just the second part of that item, if I can, please. This is asking the board to support the setup of it. It says joint committee. It's not strictly speaking a joint committee, but it is a committee of multiple places in line with the arrangements we set out in our governance handbook 12 months ago. This is the first time we've asked for this, setting up a joint committee of 3 places to manage the future governance, supporting the future phase of the Calderdale, Kirklees and Wakefield Older People's Inpatient Transformation Programme. It's in line with what we said we would do, and you're being asked to endorse that recommendation to establish the committee. You'll see within the paper that place governance leads are still working with place chairs and accountable officers to confirm nominations to the joint committee. I think 2 of the 3 places have now done that, and that you will receive minutes from that subcommittee in the future for continued assurance.
Thank you. Colleagues, are we happy to support that? Yeah, round the table. Thank you. I think my request is ICB chair is that particularly for that the setup, there's a regular update to you and I, because this is a different kind of committee. And we can see the purpose of that. I can see my name on there as well, on my job title. So I think there's just an update on how that's working and an evaluation of its effectiveness, as we do for all other committees as well. But happy to approve. Okay, thank you. I haven't received any other business, and I assume we don't have anything. Rob, do you have anything? No? Okay. Colleagues, thank you so much around the table today for our guests and visitors who have joined us in person today here in Bradford, to the people who joined us for our engagement session on looking at mental health. What I would say is if anyone has been affected by the topics we've talked about today, whether it was in the engagement session or around the table here today, we'll make sure that there's information out there, but please go through and seek support through your networks, and also we'll put some information online as well to provide support as well. Thank you, colleagues. It's been a long day already. We will now close our board meeting in public, and thank you to anyone who's been watching online, live, on record. Thank you very much.